Good morning, everyone, and thank you all for joining us here today. It's really nice for me to see this room coming together with a lot of people. We've been all working towards this event for quite some time, and many of us all have collaborated and worked together to bring this day come to life. So I want to thank everyone for that. And before we begin, I would like to acknowledge the land we have gathered here today. It is the traditional territory of neutral Anishinaabe and Haudenosaunee people. This land is part of the Haldimand Tract, granted to the Haudenosaunee people of the Six Nations of the Grand River, and it continues to be the home for many First Nations, Métis, and Inuit peoples. We recognize their enduring presence, knowledge, and contribution of many Indigenous people and communities to this beautiful land. And we reflect on the responsibility we share in continuing to learn and build meaningful relationship. Many of us here are immigrants, settlers, and also people who have been displaced. And it is a reminder for us all to learn more about the history and carry it forward to our future generations so that we can develop meaningful and respectful relationship to this land and the people here. Many of you will be having the agenda paper with you so you can look into it. So today it is about people, pathways, and the possibilities that we can explore. So here we have internationally educated health professionals, including myself, who all have been going through complex life journeys. And we also have our speakers who are here to share their knowledge and experience with us. We also have our partner from Canadian Medical Foundation, who has been a strong pillar of support and guidance from the beginning of our program, and also our community partners here. And at the same time, I also like to highlight the participants from our learning stream who have been working over the past few weeks on their projects. They have put in a lot of their time, commitment, and effort in bringing their projects to life. We will be displaying their posters outside. So when you get a time in between the breaks, I encourage all of you to go have a look at them, engage with the presenters, and continue the conversations. We will also hearing from them through their presentations over the day. Today's agenda will begin with getting to know about our community partners and their services they provide. And then we'll continue with a presentation on public health and health promotion by Pegeen Walsh. And then we will have one presentation from one of our learning groups, then continued by the profession-specific conversations happening in the 3 breakout rooms. And then we'll continue with our lunch. And then again, we'll have the rest of the groups from our learning streams presenting. And then we'll have a panel discussion facilitated by our speakers. And then before wrapping up, we'll also have a networking session where we can connect with each other and also with organizations. So I know it is challenging when it comes to licensure, employment, or even recognition, or even trying to get the right information at the right time. But organizations have been working and collaborating in order to make this as accessible as possible and as informed as possible. So today's day is about having conversations, asking more questions, and connecting with each other. Before we begin, I also would like to highlight this conference is a part of a series of pre-conferences leading to the Pegasus conference, carrying on between May 1st to 3rd on interconnectedness future. We will be displaying some information on that during some breaks, but if you need more information, please feel free to reach out to me or Dwight or Mohammed, and we'll be happy to share and assist you. And so here we begin. And for the first presentation, I would like to invite our partners from RFL to share about their work and the services they provide.
Most of you did not come to Canada for an easy path. You came here with a vision to rebuild your career, to provide stability for your family, and to eventually practice at the level that you know you're capable of. But in working with internationally trained medical professionals over and over again, we've realized that the licensing isn't just the hardest part, it's everything else around it. It's the time that it takes to start over, it's the uncertainty of it all, and the financial pressure that this causes. And that happens generally because in this phase of life, no one talks to you about money. And I'm not talking about making money. No, I'm talking about smart decisions that you make with your money. At our firm, RFL Wealth, we work exclusively with internationally trained medical professionals. So that's your doctors, dentists, physicians, surgeons, however you like to think about it. And in working with these individuals, we see that there's a pattern. Time and time again, if we look at two people that go through the exact same process, exact same exams, exact same licensing, exact same opportunities, but 5 to 10 years later, one of them is financially confident, they're thriving, and they're stable, while the other person is still working really hard, just trying to catch up. And it's not because the first person had better opportunities or they worked harder or they're just smarter or got luckier. None of these things. It's because no one spoke to the second guy about the importance of money in this phase of life. So they're still in the rat race. They're still trying to catch up. They're still trying to do all of these things. And what I want to do in this presentation, or I guess more of a speech, is talk to you about some of the biggest mistakes that we come across when we work with internationally trained medical professionals. Not so that you get worried, but that you can actually avoid these small mistakes that can end up having very, very big consequences on your life. So really quickly, I'll just walk you through some of these mistakes, and I really hope that I can save you all a lot of time and money in the future. The first mistake that we come across almost, I would say 70 to 80% of the time, is waiting until later to think about money. And what I mean is, there's people that'll be like, you know what, once I'm done my licensing, once I'm practicing, and once I make my money and I pay off all my debts, because you're going to accumulate some loans along the way. Once I do all of that and I come to zero, then I'll start planning. Because before that, what's the point? I couldn't disagree with you more. It's very, very important that you start early on and you learn early on what are the importance of money, how you should spend your money, how do you get taxed on your money? What are the best options available for you to save money? These are the things that you should be worrying about. And you don't have to start doing this right now, but you just have to become aware of it so that you don't fall into the mistakes that we commonly see. The second biggest mistake that we see is short-term decisions that have long-term consequences. I see it all the time. People take on high interest debt. You can walk into, sometimes, you may walk into an appliance store or an electronics store or a furniture store, and they'll be like, there's this beautiful couch for $5,000. I know it's really nice. You don't have to, if you want, you can actually get a credit card. You won't have to pay interest for 3 months. So realistically, you don't have to pay anything for 3 months, and you can pay for it 3 months later. You know right now if you can afford that couch in 3 months from now. If you can't afford it right now, chances are you can't probably do it in 3 months. So you shouldn't just take on high interest debt. Because if you ask them, well, what would it be after 3 months? Well, it's 19.99%. I don't want to talk about that. Let's not talk about that, right? Because it's their job to do that, but it's your job to understand to not make these small decisions because they can end up having a big consequence on it. The second thing is not making proper banking relations. How many people here have seen ads for an Apple Watch or an iPad if you sign up for an account with us? Have you guys seen them? Yeah, right. Do you know that there are other banks out there that will give you very, very good opportunities and financial instruments just because you are an internationally trained medical professional or you're training to be a medical professional and you came here internationally? And they won't give you an Apple Watch or an iPad, but they'll actually give you, lines of credit that'll have favorable interest rate. They'll let you know, hey, if you can actually save in these accounts, that'll be better for you. You can't just run after the shiny objects. It's the saying, stupid in small decisions, stupid in big decisions. If you constantly make small decisions that are stupid and you're like, you know what, this is okay. It's not gonna have a big effect. It's just one Apple Watch. It's just one account. It's $16.99 a month. What's the problem? Slowly and steadily, these stupid small decisions will trickle in to you making stupid big decisions. And it's not just you, it's everyone, regardless of what path of life you're in. And that's a mistake that we commonly see. The third mistake that we commonly see is not getting the right advice for you. Majority of the financial planners in Canada, not to their fault, give advice for general Canadians. General Canadians that were maybe born here, that were maybe raised here, that went to university here, went to high school here, grew up here. The advice that you need is not going to be the same that a general Canadian needs. You, out of all the people, should understand the importance of specialization. The reason people love working with us and the reason we have niched it down to internationally trained medical professionals is because we understand your plight. We understand the problems. We understand what you come through. We understand the obligations that you have. We understand all of these things. And then we help you understand, hey, if this is what is important to you, then this is what you need to do. You can't just close your eyes and go save your money in RSP and TFSA and all this. I'm not saying you shouldn't or you should, but you need to know if that's the right decision for you. That is what's important here. The last biggest mistake that we commonly see is when people don't position themselves early enough. It kind of culminates everything else that I've talked about. Waiting too long, making small decisions, not getting the right advice, but essentially not positioning yourself the right way and not understanding that you need to start getting aware now and you need to start learning now. What I don't need you to do is leave from here and go start reading up on investments and taxes and all that stuff. You don't need to do that right now. You actually have a lot to study about, I know, all right? But what I need you to do is become aware so that you don't make small decisions that can end up costing you years and years in the future. What I need you to do is become aware of exactly how you earn your money, just in a general sense, how you're taxed. Tax planning is way more than investment planning. In my opinion, investments, no matter what sort they are always based off opinion because they have to. Taxes are very black and white. If we can at least take care of our taxes first, then we can, make sure that we invest in all the beautiful companies and all that stuff. Sure, we'll do that. But let's make sure that our foundation is right. And being in this industry for 10 years now, constantly, we've seen that there's a big gap with educating individuals like yourself that are in your phase of life right now. We've seen that constantly. So what we've done is actually make a resource and a community for you. We've made a starter kit, which just helps you educate yourself, that helps you just inform yourself. We're actually set up right outside. If you'd like to, you can come by. We have physical copies. If you'd like, we can send one to your inbox. There's no commitment and there's no cost. What I truly want you to do is become aware and become educated so you can then create stability for your family. You can remove the uncertainty and so that you can live your rich, fulfilling life. Because what that means is something completely different to everybody. And I would implore that is the most important thing for you guys right now and concerned to money. With that being said, my name is Usman Jamal. I'm the CEO at RFL Wealth. I've had the pleasure of working with 100 plus physicians, and it's honestly the most amazing thing ever. I want to thank University of Waterloo for actually setting up an amazing program like this. And thank you very much all for listening to me. Have a great day, guys.
Thank you so much. I'm sure many of you will have found this information incredibly helpful. And like you mentioned, there is a booth outside. So when you get breaks, please feel free to stop by and get more information and connect with them. So up next, we have Gillian and Philip from Thrive to talk about the organizations and the services and the different kinds of reach they do in the community. Hello.
My name is Jill. I'm the Youth Sexual Health Coordinator at Thrive. A little bit about our organization. We know that one of the worst things we could do is silo ourselves and expect that we can do everything. So it's really important. And what's really cool about this conference is that we can learn about different community organizations that we can work with to offer kind of a holistic approach to care. Specifically in the youth department, I work with youth aged 12 to 29, offering prevention education on sexually transmitted and blood-borne infections. But as a whole, as an organization on a whole, we offer a plethora of services. Some key services I would like to highlight are rapid HIV self-tests that are completely anonymous and confidential. HIV non-disclosure is still criminalized in Canada. If you have any further questions about that, we will have a booth if you want to talk about that. But we're one of the only organizations in the region who offers anonymous HIV testing where we are not reporting results. So that's a key service I'd like to highlight. We also work with a lot of folks who use substances. So we have a needle and syringe pickup program. So folks are using new needles and not sharing needles, which can increase the risk of blood-borne infection transmission. And I'm going to pass it over to my colleague to talk a little bit more about his program, as well as just some of the stigma that still exists in the community.
Hi there. I'm Philip Charbonneau. I'm the MSM coordinator. My program deals with gay and bisexual men and other men who have sex with men. But Thrive as a whole has a whole bunch of higher risk communities that we work with. So youth, we've already talked about. The MSM community, which as I talk about, we also have a women's program, a program that deals with ACB folks and other racialized folks, and then the people who use injection drugs and other sexually transmitted and bloodborne infections. And they are this way because of stigma that exists in the world around HIV, people not feeling they can be comfortable disclosing their status to partners, people not getting tested because they fear both the stigma of if they do have HIV, but just the fear of even going tested because there's a lot of stigma around safer sex and STIs and bloodborne infections out there. And so we work to try and lower those barriers to getting tested, lower the barriers to preventative measures like PrEP and PEP and other things that are out there, condoms and lube and so on, and educate the population as best we can about how they can protect themselves. But as healthcare providers and people who work in the health industry, you are also on the front line of this. And so we love working with people like you to get education out there to the patients that you see, to the communities that you're in, and to make safe and inclusive environments for people to feel safe to come into, to talk about their sex life, and their HIV status if they're HIV positive and so on, without fear of discrimination, without fear of racism, without fear of homophobia or queerphobia, and all the other things that prevent people from going in or being stigmatized for their drug habits, for instance, is another big barrier. And so as healthcare professionals, if you could locally hook up with your local AIDS service organization, make that connection, learn about what we do in your communities, and establish relationships, it would really help out the cause of really reducing the amount of sexually transmitted and bloodborne infections that are out there. So we'd like to get it down to none and support the people who are living with HIV to live happy and healthy and full lives, which they can now because of the current situation on HIV treatment. All right. Thank you very much.
Thank you very much. I believe as IEHPs, it is very important for us to engage with inclusive services like like Thrive themselves. So I would recommend that you engage with them and try to understand what their programs are and how you could contribute or explore similar services in the areas where you're coming from. So thank you very much for the speech, Gillian and Philip. Thank you very much. And up next, I would like to invite Stefan from Conestoga College to talk about their program on Bachelors of Allied Health Services.
Thank you for inviting me. Thank you for organizing all this. Never knew about it until 2 days ago. So I'm going to be brief, only 3 slides, one of which is all about myself. Feels like a support group as I start with my talk. I'm an internationally educated medical professional. I did my medical degree back in Romania in the 90s and always been interested in computing. And now you can see how that pays off. I started my residency in medical imaging, but then I had to move for my PhD at the University of Victoria and completed that in 2006 with a dissertation on topics of AI of all things. I think I was a bit ahead of its time, no? I still have a lot of things to say about AI. Since 2007, 20 years ago, almost. It's crazy how time goes fast. I've been teaching full-time at the college in this degree program we had there. And right now, after witnessing all of these change that we went through, it is time to provide some pathway for other people with healthcare backgrounds to move into these roles of health informatics. So this is what I've been dreaming about, this online degree, just a degree that could benefit from the wealth of knowledge that people with healthcare backgrounds have, combined with a desire to pursue great things with computing and these days with AI. So we build this educational pathway on top of this 4-year degree we have at the college. So we're going to rename it. It's going to be a bit of change there, and we're going to have the IEHPs in mind as we progress with the changes. And we try to leverage their experiences and knowledge and give them the skills to transition into roles of health informaticians that really, really highly sought after. I don't know if you know a few like those, but they're very highly sought after. So people with healthcare backgrounds that can relate to computing and technology and all of those things, including the new developments, AI and such. This is it. If you're interested, or if you know anybody who's interested, please feel free to talk to us. And I would love to elaborate. There's so much to talk about, so many courses to describe and to see what you could benefit from. And me and my colleague, Kathleen, right there, we're ready to answer and hear your stories and answer your questions about this possible pathway for your careers. Thank you so much.
Thank you, Stefan. As IHPs, we are trying to also explore the diverse health professions or alternative health professions that we can pursue while pursuing license or choose as our career itself. So it's an excellent opportunity for everybody to engage and know more about the program. Thank you very much, Stefan. And before moving on to the next session, I would also like to welcome Dusanka from Canadian Medical Foundation. Like I mentioned, they are the partners with our program, who has been a very, very strong guidance factor since the beginning of the program. So I would like to welcome Dusanka to talk about Canadian Medical Foundations.
Hi, everybody. I'll keep it short. I know everybody's eager to get to the sessions. My name is Dusanka. I'm the president and CEO of the Canadian Medical Foundation. And a few years ago, we had started working with Indigenous medical students and Black medical students to try to do our part to add some diversity to the health workforce. And our board said, well, is there any way we can also help immigrants and refugees who are health professionals back in their home countries? And especially today when we have such a crisis and a lack of healthcare workers. As an immigrant myself, this really resonated with me. As many children of immigrants also know, I used to go with my parents on all their medical appointments to translate, even as 10 years old, because that's what you do. And I remember my mother would act very different with health professionals or doctors from our area. It doesn't have to be from our country, but from our area versus, Canadian ones. She just wasn't as comfortable speaking. And obviously that wouldn't give her the best health outcomes either. And I was always very confused. She'd be much more forthright with people who are from our region. They'd understand me better. And I didn't understand that. But it became obvious to me that representation matters very much. And also, growing up again in the immigrant community, so many people I met were doctors back in their home countries and couldn't find work here. And obviously I saw their frustration and their sadness, losing so many years of practice and so much education to do nothing here, and especially when we have such a need. So when the board said, can we do anything with immigrants, I jumped and I called Dr. Neil Arya, who's the chair of Pegasus, and I said, is there anything we can do? We have a bursary program for Indigenous medical students. What can we do? And we talked for a bit, and he said, you know what I hear more and more? There's so much information out there for IHPs, so much information. It's almost overwhelming. Back home, they can go and they can talk to a friend of a friend who's a doctor or nurse, and they can get some tips and some advice. They don't have that network here. They don't know anybody maybe who's in the industry. And it's so confusing with so much information, and some of it's not updated. So they go into one website somebody recommends, and it's either old information or it's not been updated. He goes, what's really could be valuable is a pathway. So Pegasus held a session, a focus group, and that was the feedback that was received. That was in 2021, I believe. And there were a focus group, and they said, yes, absolutely. We, having somebody to help with pathways, just to have it make sense. Like, we're not going to answer all the questions, but we can help lead them along the pathways. And so the website was launched, and then through feedback, a series of webinars was launched, and then through more feedback, the mentorship program that Dwight is over there manages was launched. And we have great plans for the future as well, with more help with the navigation, with other things that we can do to make it easier for everybody to achieve your goals. So we're looking forward to that, and we're looking forward to the rest of the day today. And I want to welcome everybody for coming here, and also everybody online. The sessions will be available for people who weren't able to come as well. So I hope you get some value out of it. When I used to go to conferences, even before any conference, I thought, even if I can get one little nugget of information, just one, that'll help me in some way or shape, that would be great. So I hope you get a lot of little nuggets today, and enjoy your day. Have a coffee.
Thank you, Dusanka. Yeah, so now we move on to our first session on public health, exploring the diverse career opportunities in public health and health promotion by Pegeen Walsh. We're really, really happy to have you here today. Thank you very much for coming. Briefly about her. She is an instructor with and developed the curriculum for the health promotion component of the bridging program, Alternative Careers in Health Promotion and Education for internationally trained physicians, hosted by the Learning Enrichment Foundation. As a former executive with the federal and provincial government and nonprofit sectors, she oversaw the design and delivery of a wide range of programs, policies, partnerships, advocacy, and research that supported individual and community health and well-being. In her past leadership roles, as Executive Director at the Ontario Public Health Association, Director of Chronic Disease Prevention at the Ontario Ministry of Health Promotion, Ontario Regional Director at the Public Health Agency of Canada, and Health Canada, she led such initiatives as climate change and health, prenatal health, early child development, seniors, injury prevention, HIV/AIDS, SARS airport screening, Aboriginal Head Start, Smoke-Free Ontario, the built environment, alcohol misuse, chronic disease prevention, healthy eating, and healthy equity. A round of applause for that. So she values volunteering as board member of Bellwood Centers for Community Living and co-chairing its Community Advisory Council. I hereby welcome you to have the stage and share your expertise. As a public health personnel myself, I'm very excited for this lecture. Thank you.
So good morning, everyone, and welcome. I'm really honored to have been invited to come to this session. I do teach an online course, and so I see that we have a lot of people online. So I am keeping you in mind as we go throughout this session. And so I'm assuming that people have the ability to put comments and questions in the chat box. So perhaps if you can keep an eye on that for me. And this session is 45 minutes. And while we had planned to have questions at the end, I do welcome questions and comments throughout. And if I find we're getting a bit away from some of the areas I want to cover, then I'll just mention that to make sure we get through the presentation. So today I want to talk about health beyond healthcare and to explore those career opportunities in public health. I'm going to talk about what is public health, what kind of a career you can have, what the opportunities look like, what kind of skills you'll need. And I hope by the end of my remarks that you're going to see how critical this area is and consider it as a possible avenue. Look at ways that you can transfer the incredible skills and experience that you have into this exciting field. So as mentioned, I'm going to start out with a bit of background, because in any job interview with public health, people want to make sure you understand the concepts that are behind it. And well, what do people think who work in this field? Why do they go into that field? What kind of positions? We'll go through some job titles, what kind of skills you'll need, and then the kind of skills I presume that many of you have that are easily transferable into this area. I can give you some examples of opportunities that are open right now, so we can go through those and look at, well, what would be required to apply for that kind of job. And then at the end, I provided some training, some free online training that you might find useful, some tools and different kinds of resources. So to start out, I just wanted to ask you to do a quick poll, if you wouldn't mind getting out your phones. And for those of you online, you'll see a poll come up on your screen. And we'll just take a moment to answer these questions in terms of, what do you think are the most important factors that influence your health? Is it our genes and biology? Is it socioeconomic factors? The healthcare system, having access to those services? Is it the behaviors? Is it our health behaviors? Or is it the physical environment that we live in? So just to choose one factor that you think is the most critical. Okay, so what we're seeing here is that a few people are saying, it's really about our genes and biology, and we can't control those factors. Others are saying it's about the healthcare system. Can we access those services that are going to keep us healthy? Others feel that it's the way we behave. Is it about healthy eating, being active, or is it the environment in which we live? And a large number of you recognize that social and economic factors play a huge role. And I'm pleased to see that because that's what we're going to talk about. In public health, we're very interested in those root causes. What are the non-medical factors that are going to keep us healthy? So there's been a lot of research done internationally and in Canada to understand what are those factors. And this pie chart shows you that those socioeconomic factors, in fact, play 50% of the influence of our health. So more and more studies are coming out showing those of lower socioeconomic status tend to have poor health. And we're further research to understand, well, why is that? And what can we do about that? So I think for some people, they find that surprising that the healthcare system, while it does play a critical role, and we need it there, and we often feel like we need more services, but how do we keep people out of the healthcare system? How do we tackle those other factors that are going to promote health and well-being? So in public health, we not only look at the World Health Organization's determinants of health, of course, we need to be living somewhere where it's peaceful, where we have shelter, where we can have food and income, and we have sustainable resources, social justice, and equity. So we know these are prerequisites to health. But on the right-hand side, you also see this rainbow. And this is really showing you what we could describe as the determinants of health, how all these factors layer upon layer influence our health. You can see in the yellow, the individual at the core, and of course our genetics play a role, our gender, our age. We also see those behaviors. They are really important and critical to our health. And we see the kinds of services that are out there, be it access to health or access to other infrastructure such as recreation, education system. And then what about where we're living and working and studying? Is that promoting our health? Are we getting a decent wage? Do we have access to clean water? And then on a broader scheme, what about those socioeconomic and political factors? Do we feel a sense of agency? Are we experiencing racism? Are we experiencing poverty? And what role does that play around our health? So I mention this because if you go for an interview in public health and you don't talk about the role in terms of health, people will be concerned that you're bringing a narrow view of health. And you'll notice when I talk about health versus healthcare versus public health. So in Canada, we have a public health system and it is separate from our healthcare system. And that's really important because sadly, what we're seeing is the majority of resources go into healthcare, and that is critical, and we don't want to see that diminish. But unfortunately, only about 2% of provincial health budgets are spent on public health. So what does public health look like and how does it influence health? So I want to just talk a bit about what I see in my own community. So I'm excited to be here because I actually studied at the University of Waterloo and I'm from Kitchener. So it's nice to be in my hometown, but for many years now I've been living in Midtown Toronto. So I want to describe a bit a day in the life so you can see how public health is there, but so often it's not really visible to us, yet it has a huge impact. So I'm getting up in the morning and I'm thinking, okay, I'm going to go to the gym. I like to work out. But, I'm going to wash my face before I head out. And as I'm washing my face, I'm thinking, wow, we take that clean water for granted. Yet we know in parts of Canada and in Northern Ontario, there's some boil water advisories and other parts of the world that clean water is so fundamental to our health. Then I'm brushing my teeth and I'm thinking about my recent dental appointment and how expensive it was. I was shocked. And I thought, thank goodness I have access to a former employee's dental program. And thank goodness public health advocated for access to free dental care for children. And our chief dental officer in Ottawa at the national level advocated for a dental program across Canada so that low-income people can get access to good oral health because it is fundamental to overall health. So now I'm walking out the door and I'm walking by this beautiful wide boulevard in our community on the way to the gym. And it's a place where the community gathers, where children play. And we know from public health doing research about the health benefits of green spaces. There's also play structures. We know how important recreation is and having access to our children. So again, public health is active in promoting the importance of a green canopy to not only absorb those CO2 gases, but also to promote our own mental and physical well-being. So I'm walking another block and then I see the school where my daughter went to grade 7 and 8 and it's being renovated. And I think, oh, thank goodness in grade 7, 8, she was one of the first cohorts that got free access to HVP. So to prevent cervical cancer. So this is fantastic that she got access to that, and that awareness has been built about how vaccination and immunization can make a difference. She also was one of the first groups that was required to have 20 minutes of physical activity every day on top of the phys ed. When I started at OPHA, many years ago, I was delighted that the Ministry of Education approached public health officials like myself and my colleagues for advice about the health and physical activity curriculum as they were updating it to make sure it included things such as sexual health. And so that my daughter would not only be learning about substances, but also how to maintain sexual health. And while you could say, wow, that's a young age in grade 7, but we know kids need that knowledge at an early age. So now I eventually arrive at the gym, and I'm going through my program, and I'm doing sumo squat jumps, and I'm doing lunges, and I'm doing step ups, and I'm doing an exercise where I lie on the ground and I have to get up 10 times. And as I'm doing that, I'm thinking about my now deceased aunt of 96 and how she had many falls. But fortunately, as the hospital saw that record of her repeated return to hospital, they launched a health promotion initiative for injury prevention for seniors. And I'm thinking, this is great that I'm doing these exercises so that I will maintain my core strength, weightlifting, and be active. Plus, every day I feel great because I'm working out. So again, in public health, part of the mandate of public health units, for example, is to prevent chronic disease through physical activity, healthy eating, and what have you. So now I'm leaving the gym, but I am thinking, wow, I'm so lucky. I found this inexpensive place, but what about other people? Why isn't that integrated in our health system? When I walk by the family health team in our neighborhood, I'm thinking, wouldn't it be great if they could integrate in that team physical activity specialists, registered dietitians, so people can get easy access to this kind of knowledge and be active. So I'm walking down the street, I'm going by my hairdresser, and I'm thinking, oh, I'm so glad that public health is inspecting the hairdressing salons so we know that the tools that are being used are safe. There's something like 5 or 6 nail salons. I don't know about in your area, but they just seem to be expanding. And again, those are being inspected by public health. I look at the corner store and I'm thinking about all the work that public health advocates did for decades to create Smoke-Free Ontario. So that you go in that corner store, kids don't see cigarettes. It's been denormalized. They're hidden behind. Their age is checked before they can purchase cigarettes. And there's no smoking in those public spaces. What a great feat achieved by public health advocates across the country and in Ontario in particular. So I'm walking by the pharmacists, and I'm excited because the gentleman I've gotten to know, he's from Iran. He was able to get his credentials recognized. And so I had been there for my flu shot and my COVID shot. And I thought, wow, it's made such a difference opening up vaccination through a pharmacist. It's so easily accessible. And guess what? We've seen increase in immunization against flu. Now, COVID, that's a whole other story in terms of the incredible work that public health did to keep us all safe. And it's sad in some sense because people don't really want to talk about what happened. But sadly, so many vulnerable members of our community did lose their lives. But in comparison to many other countries, we did very well in Ontario and in Canada. And again, critical role played by public health. And sadly, now feeling a bit misunderstood, a lot of misinformation too about vaccination. So I'm almost home. I'm going by the grocery store and I'm thinking, oh, thank goodness again for the hard work of public health, so that when I go purchase something, I can see, is it high in salt, high in sugar, high in saturated fat? So that was a long struggle to get that front of packaging. And I know the Heart and Stroke Foundation has been working with a whole range of public health advocates to try to restrict marketing to kids. And they've come so close to legislation on that. So that work will continue to make it easy to eat healthily. And one of the really proud achievements that we did at the Ontario Public Health Association was to make sure when you go into a chain restaurant, you will see information about those calories. So you have an awareness about what is appropriate amount of calories for an adult or a child, and what do I see on the menu. So now I'm almost home. And as I come into my house, I'm thinking about the newspaper, and it's going to give me good information about UV so I can protect myself. is going to give you information about air quality. Again, things that public health have advocated for to ensure that's there. There's all kinds of other things. When you see up here, I've talked about protection, I've talked about promotion, and I've talked about prevention. So those 3 Ps are critical to public health. And I'm about to join in a conference call with colleagues from the Bellwoods Community Center for Independent Living. So I've been doing some advocacy work with those who have physical disabilities because they're feeling that those barriers could be removed and their needs are not being met. And so I know that being a retired person, having social connection, having purpose, meaning, and contributing is also really critical for health. So these are, I've tried to show you through my day, just thinking about my community, all the ways that public health is making a difference in people's health, getting at that root causes through public policy, through individual action, through working with groups, through spreading knowledge and awareness and doing research. So as we go through this, I hope you'll keep in mind, I don't know how many of you have really thought about public health or aware. For example, do you know what your local public health unit is called? Do you know where it's located? Have you benefit from the services? For example, when I was, after I had a baby, I was so excited to be able to go and meet other moms and get information from public health so that I could survive, especially those early weeks. So I've just touched on some of the critical areas that public health is involved with. I wanted to talk about Canada's public health system. So again, we have a healthcare system in Ontario, but we also have a separate public health system. So I'm wondering if you would mind just reading for us the purpose, aims, and what some of those functions are, since you have a background in public health.
Okay, so the Canada's public health system, the purpose is to achieve optimal health and well-being for all people living in Canada. Very important. And the aim is what the public health system is trying to achieve. Enhance the health status of population, protect against health emergencies and mitigate the impacts, and achieve equitable health outcomes. And the essential public health functions is in how the public health system works to achieve the aims. So first by health promotion, then by health surveillance, health protection, population health assessment, disease and injury prevention, and emergency preparedness and response.
Great, thank you very much. So you can see those 6 areas. And you'll see in the appendix of this presentation, I've got more details about what kind of credentials would you need in some of these areas. And I'm going to focus my remarks more on the health promotion area. But I do have a background in emergency preparedness. I've worked in that area. I'm also going to talk about disease and injury prevention. And I know some of you got that background and expertise and credentials around population health assessment and health surveillance. So I'm happy to answer questions or point you in the right direction around those areas, but I thought it easier if I just hone in a few areas where I've had more experience. So again, I wanted to just try to differentiate when we talk about healthcare versus public health, what are the key differences? So you can see in public health, it's very much about proactive prevention. So yes, you might have a disease, you want it to not get worse, so you're trying to prevent that, but that's not primary prevention. You're looking at secondary prevention, or you might do screening tests. So again, that's not primary prevention. You're not getting at, what is that disease? You're trying to understand what are the root causes to prevent disease, injury, and health conditions before this occurs. So on the left-hand side, we see public health is very much about our communities. We're looking at a population level. We talk about population health. We may look at specific groups within the population, but we're not looking at individuals the way that you would in healthcare, where you're dealing one-on-one with people. You might go to a public health clinic that might involve a number of people, but you're doing it because you're trying to overall improve the health of that community. And the kinds of science you're going to use, you're going to look at data, for example, epidemiology. You're going to use social science as well, because you need to understand people, their behaviors, et cetera, versus on the healthcare side, you're looking more at that biological science. And I think the biggest challenge of public health is it's kind of diffuse. As I described to you, when you're walking through my neighborhood, you're not necessarily thinking the way I think. There's a lot going on there, like, oh, there's public health, there's public health. You're just enjoying the neighborhood and not necessarily appreciating all the ways that public health might have been working to make that community a healthy one. And versus, I think, healthcare, we all understand it. We know what primary care is, what the doctor does, what nurses are doing, where the hospital is and what have you. So on the next slide. So if you were to ask people in public health, why do you work in this field? What do you enjoy about it? People would say, well, I want to make a positive impact on the lives of others. So I'm sure that feels familiar to many of you because that's what probably motivated you to get involved in health. You want to make a difference. There's varied careers that you can have. I'm going to show you in a minute the different sectors where you can do. You've seen the different kinds of functions that are involved, and people rate, high job satisfaction. Now, in fairness, coming out of COVID, I think whether you're working in public health or other parts of the health system, there's been a lot of burnout and frustration. So not everyone right now is going to necessarily say, I'm really satisfied with my job, but I know the kinds of things that people do in public health, they find very satisfying. And there is that chance to work at that broader level. How do I influence policy and laws, regulations, so that we're looking at those root causes and making a difference for the whole community versus just helping one person. I used to work at YMCA Canada at one point to try to support them around advocacy and public policy. And I said, you'll never have enough services, programs, and volunteers and money unless you're also looking at, okay, why are we finding young people on the street? Why are we finding young people dropping out of high school? How do we look upstream at those root causes and try to influence those? Because this part of dealing with the problem, it's just going to be a very expensive and never ending. Okay, so in the next one. So as mentioned, there's various areas where you're going to find public health. You're going to find it in government. For example, was mentioned, I worked in Health Canada. They have regional offices across the country. The Public Health Agency of Canada is very much that scientific technical agency. Across Ontario, we have every part of our province is covered by a health unit. There are 29 local public health units, and they have a mandate from the Ontario government that's outlined in the Ontario Public Health Standards. So you can read about the work that they do. You'll find in more and more in healthcare. We're finding in hospitals there, as I mentioned, health promotion, injury prevention. We're finding it in family health teams are adding health promotion specialists. We heard earlier from some community organizations that are tackling health issues and using community development and community engagement principles to respond to some health issues. You'll find settlement agencies are also tackling health issues and all kinds of health charities. I mentioned Heart and Stroke. You have Canadian Cancer, Diabetes Association. Also private industry, insurance companies are realizing, okay, we're spending a lot of money tackling health conditions. Is there a way we can prevent that? Pharmaceutical companies. International organizations. I found a number of people that I've been involved with in our program have found some employment with the Canadian Red Cross here in Canada. So not necessarily working on an international level. And of course, we heard about the academic sector, and there's research organizations for those that are really interested in data. So we've got universities, we have colleges, we have an organization called Public Health Ontario, which is sort of like the Centers for Disease Control here in Ontario, a technical scientific agency, and we have Canadians Institute for Health Research. One of them is focused on population and public health. So here's a sample of some of the job titles that you might see. So we can see, I talked about, you might have a title, health promoter, health educator, health promotion planner, a policy health analyst. You might have a leadership role. You might be a supervisor, a manager, a director, an executive director. You might be a global health specialist. You might be a community health worker, a health promoter working on drugs and alcohol, or perhaps working on environmental health. You might be an infectious control specialist, maternal and child health specialist, or working in mental health and addictions, or managing chronic disease and injury, or facilitating community programs. You might be a manager of communicable disease, might be an occupational health and safety specialist, a workplace wellness coordinator, a supervisor of family health, health promotion planner, mental health, epidemiologists, public health researchers. So I gathered all these titles from past jobs that I've seen, as well as areas where I've seen some internationally trained physicians obtain employment. So what kind of skills do you need in public health? So the Public Health Agency of Canada has put out a document, and it's called Public Health Competencies, or Competencies for Public Health. So you can find that online, and it goes through over 60 different kinds of skills, but they've grouped them in these 10 areas. So you can see there's sciences, of course, there's assessment, analytics, policy development analysis, program planning, implementation and evaluation. There's public health advocacy, communication, partnership, collaboration, leadership, health equity, social justice, ethical, and reflective practice. So this document will go into, in the details, as I say, 60 odd different skills. So depending on the kind of role, no one's expecting you're going to bring 60 different skills. So under each area, you'll see what is needed. So for example, I pulled out 3 areas. So in program planning, you can see the expectation is that you can plan, implement, and evaluate programs to address those root causes of health inequity and promote population health. And in working in different internationally trained physicians, I found that many of them have done outreach work. They see people coming into their clinic, they're trying to understand why they're seeing a certain condition, and they realize the need perhaps for reaching out to the community to raise awareness, to do education, and design a program that might make a difference. So I just mentioned that because I assume for some of you might have had that experience. Communication, all of you are involved in communication, I presume, unless you're doing some kind of a data. But even then, if you're doing analysis, I'm presuming you have to present it or talk to someone. So again, a critical skill to inform, influence, motivate, engage individuals, institutions, and the public to address public health issues. And then partnership is a really critical part. That is working with others. So again, I'm assuming in the health settings that you come from, you had to collaborate with others. You had to figure out things together. So again, in public health, that's really critical to build those kinds of partnerships and coalitions in order to influence health. So often it's other sectors that we need to work with because they may hold the levers that influence health. So I'm not going to go into this in detail, but just to know when you receive this presentation, it goes into more specifics around, okay, what do you need for a role in health promotion? And again, you would find that not only in the Public Health Agency of Canada, but there's an organization called Health Promotion Ontario, and they worked at refining these competencies. So again, you can see this partnership building, working with communities, knowledge of how to plan something, and being proficient in many languages, a huge asset, and having lived experience. So as we look across our province, it is so diverse, and having people who can understand, as we heard our earlier speaker talk about, hey, I can relate to you more because you've been through this kind of experience. So I wanted to do a quick poll again, just to see how many of you might have already had some of these kinds of experiences and skills and abilities. Not every role requires all of these skills, but we can see that some of you already are bringing those skills. So I'm not going to go through this in great detail, but what I'm trying to show you is, okay, on the left-hand side, you'll see work that you've done in a healthcare setting. And then on the right hand, how can you talk about it using terms and translate that into a public health world?
Counsel patients about medication, diet, or prevention.
Okay, so in public health, we would talk about, and you'd put this on your resume, that you've delivered health education using plain language and culturally responsive communication. So you can see, and I've seen this in physicians' resume, for example, they talk about, oh, I talk to patients about their medication. So someone working in public health, they're going to say, well, how's that going to help work in health promotion? So you can see how using the right terms can be helpful.
Manage patients with chronic diseases.
Okay, so in public health, we talk about applying knowledge of chronic disease prevention, determinants of health, and barriers to care.
Rounds, clinics, and team huddles.
Okay, so we would describe that as you've collaborated with interdisciplinary teams, you've prioritized needs, you've coordinated service delivery. And of course, in public health, because we're concerned about equity issues, it's important to talk about, have you worked with vulnerable populations, those that are marginal? Have you worked with different age groups?
Worked in infection control or safe clinical practice.
Okay, so we would talk about risk reduction, infection prevention, quality and safety practices. So you can, as I say, after the session's over, you can look more closely, but the idea is to think about the roles that you've played and those abilities that you have, and how do you use terms that would resonate in the public health world, and in the so that you can do that translation. And speaking of translation, if we can see there's all kinds of transferable skills. So whether that's communicating, presenting, writing, influencing, interpersonal skills, showing empathy. I'm sure all of you have that strength because it's something that you're required to do all the time. Initiative, resourcefulness, figuring out, how am I going to solve this? How am I going to get this done? Planning, organizing, problem solving, decision making. These are all critical skills in public health. Analytical skills, using evidence. So again, in public health, we're not just making up something like, oh, I see a problem, we should do this. We're going back to the evidence. What do we know about this? What works? What interventions are going to be most effective? And then that knowledge of health issues and conditions. And one of the things I would strongly encourage you to do is to keep au courant. So keep up with the news, whether it's newspapers, whether it's online, whether it's journals, because one of the unconscious bias you're going to face is, oh, you don't know our system. So you want to be able to show people without being asked, oh, I understand all the parts of the Ontario system. I understand the difference in public health, and looking at different issues, I know what's hitting the headlines, because this is where public health agencies and organizations are going to be focused on what's most pressing, what's getting attention, what are politicians concerned about, what is the public concerned about. So you want to show that you're up on the latest. So I wanted to take a moment and just look at a job description. So in this case, we see a Grey Bruce which is around the Owen Sound area of Ontario. And oh, guess what? They're looking for a bachelor's degree in health studies. So all of you are way beyond that. So you meet that requirement. Sometimes you might see masters of public health or equivalent education experience. So again, you can certainly show how your experience and education meets that requirement. Okay, knowledge of health promotion practice, health status, populations, health inequities, health determinants. So it doesn't say that you have that ability, it's saying knowledge. So this is something you can read online, and you'll see in my appendix, there's a health promotion online free course at Public Health Ontario. So there's all kinds of resources and online training courses to make sure, like, oh yeah, I know that, or I didn't describe it that way, but I get it. And then that ability to develop, implement, and evaluate community health-based initiatives. So we already have some of you that have said, hey, I've already done that. So for others, are there ways you can get that experience? Could you be volunteer, for example, at a community health center or a public health unit or a local health organization, a community service organization, where you might learn more about how are they planning initiatives that improve community health. And then this part, okay, leadership skills. Okay, so all of you, have been independent agents working with others, having to show leadership. So using your communication skills, assessment and analysis. So as those patients are coming in, you're doing assessment, you're doing diagnosis. So in a population health level, you're looking broadly, not just at the individual. What does this mean for the community? What are our chronic disease rates in the Kitchener-Waterloo area? And then that experience in building partnerships. So you can see in that job ad, you might say, hey, I think I could apply for that. One of the things I would suggest you do is to make sure before you start applying for roles that you ask someone who's been working in this area to give you some feedback, because I have seen people applying and feeling frustrated. Then I look at the resume and I'm thinking, oh my gosh, one gentleman I was talking to, he was describing a proud achievement, how in Pakistan, he was in charge of emergency preparedness and flood. There was a huge flood, and he worked with all these international agencies. It's like, where is that? Another gentleman talked about a cholera outbreak. So as an employer, when I look at that, you say you managed a cholera outbreak. So I'm not thinking necessarily of the disease. I'm thinking, wow, that's a leadership role that has huge impact, and you prevented the spread. So it tells me a lot about your skills. So I've got two others, but I'm just looking at the time, and there's something you can look at. This is in a public health unit. This one is in a community health centers. So community health centers are a fantastic way to get your foot in the door, because they have primary care, but they also have health promotion, and they are 101 community health centers in Ontario. So you do want to read about those, and you can see more requirements, but also because they serve so many communities where we find many immigrants, refugees, newcomers, they really value people with different language skills who have that lived experience. And then we see in Mississauga, in a family health team, a health promotion specialist. So for example, you might be doing diabetes education there. So again, when you look at some of these concepts, you might say, yeah, I have those, or I feel I could easily gain those. So I did want to mention that for those of you that are internationally trained physicians, I have been working for the last 6 years with a program that is run by the Learning Richmond Foundation, and it is an online program. And we go through what is Canada's health system, Ontario's health system, principles of equity, health promotion, communication, social marketing, advocacy, integrating health promotion and healthcare. There's a whole range of topics. Plus there's also, as you see, business communication, career planning, a range of guest speakers. So it's something to check out if you feel that would be helpful for you. So as I mentioned, there are different places where you can go. Public Health Ontario has events. They have online free webinars. They have online course on infection prevention and control for those who want to specialize in that area. The Canadian Public Health Association is a good way to keep up with what's going on. They have newsletters, they have job postings, they issue reports on critical public health issues. On the next slide, you can see some other organizations I was mentioning. This is a young person who has a master's in public health, and they started this online place. It's got a career club. They do book reviews, newsletters. They post jobs. So it's a great place to go. Oh, there you go. So there you see. There's also these other centers across Canada. And for example, methods and tools where you can find lots of webinars, online courses, videos, reports. So again, great source for information. You can see the Alliance for Healthier Communities. They post job opportunities across Ontario working in community health. They have a free online course. Social prescribing is something that now people are looking at. The issue of loneliness, especially among seniors. And there you can see some other webinars and courses. And then all of you, I do encourage you, and one of the things we do of our course is a module on Indigenous health to understand why are we seeing this disparity among Indigenous people, and to understand that history and the things that happen, how colonization impacted Indigenous people. So again, there's a whole center there where all kinds of terrific resources. So I just want to conclude by saying there are a lot of challenges out there that now we're seeing that chronic diseases are the biggest burden, if you will, on our healthcare system. Yet we know something like diabetes, 50% of it is preventable through healthy eating and increasing physical activity. We also know those other determinants of health, though, could be the ones creating problems. For example, in Peel, Public Health did a study realizing the way urban sprawl has happened in the Peel area has made people more vulnerable to having type 2 diabetes. So understanding the role of the built environment, how to prevent those diseases and conditions, understanding the impact of climate change is going to have a huge impact. Already we're seeing it with Lyme disease, for example, increasing as the climate warms up. Those ticks are moving further north. We're seeing vaccine hesitancy, unfortunately, after decades of success, issues around young people in terms of addictions, mental health, and a lot of issues around misinformation and public trust. So in my mind, public health is like a ripple effect. You know, you have that intervention and it has an impact across a broad community. It provides that opportunity to improve health, to create new knowledge, and to work with others, and often at a low cost, in order to impact a lot of people. So I hope through my remarks in terms of understanding what is public health, how is it different, what kind of skills that you need, where those opportunities might be, the transferable skills that you bring, that you will consider building a career in what I think is a really dynamic and exciting area. And I know that can be super challenging. My daughter sadly was laid off along with a number of her colleagues, and she's been looking since November. And so it takes a lot of persistence. And so I know you bring that determination, you bring so many strengths and assets. And so part of it, again, through Pegasus, this idea of finding a mentor, someone who can help translate, help you realize, okay, what is it that I'm bringing? How do I translate it in a way that the employer will understand? How do I tailor my resume, understand the job requirements? And then when I'm in interview, how do I speak with pride, but humbly about what I've achieved and what I can contribute? So again, I wish you all the best. And it was my pleasure to be able to share my passion and knowledge about public health. And I'm happy to answer questions.
So much, Pegeen. It was very informative, very comprehensive, and really, really appreciate it. I'm sure people might be having questions. After the event, you can have the recordings on website. So if you need to access this information, you can access them through the website as well.
That is a terrific question. And on my way down here, I was thinking, okay, what is the size of the public health workforce? And I used to have some data, for example, at the national level, there are thousands of jobs at Health Canada and Public Health Agency of Canada. And I think in public health units, again, you're looking at probably 8,000 positions in public health units, but we also have all these other organizations that are doing public health. So we're not counting health promotion in part of the healthcare system and in social services. What I have found, because I've been running this course now for about 6 years, I have found more job postings. So I find that encouraging and curious too, a lot more health promotion positions. So I'm thinking, okay, it must be that if you ask people maybe 30 years ago, health promotion was not as widely recognized and understood the role that it can play. So I think people are appreciating, wow, this is great to have a health promoter on our team. And I have seen more of those positions being posted in the last year than I have in the past.
Thank you, Pegeen. Is there any more questions?
Thank you so much. Internationally trained public health profession. Do you need to register here?
So you need to
Register to be a public health officer in this country?
Every public health unit has a medical officer of health who oversees that health unit, and they would be licensed doctors and specialized in community and preventative medicine. So let's say you want to work in inspection, you need to be certified. If you want to work in infection prevention control, you need to be certified. If you want to be a health promoter, you could have a master's of public health, or you could have, it sounds like the experience that you have. So for example, I've worked for 43 years, and most of that has been in public health and health promotion. My background is political science. I am not a physician. I am not a nurse. So what I did learn working in government is how to get things done, how to bring people together, and all the knowledge I gained through working with experts and reading and attending events and what have you. So the skills were, my boss used to say, you have a can-do attitude, you know, like, how am I going to keep that? All this group that's fighting with each other, we want to deliver a child development program. How am I going to get everyone focused on that and make sure we're getting to the end result? So, and you can see dental hygienist, you're going to need certain credentials of public health nurse. But that's why I talked a lot about community health and public health promotion, because those are things I think it's easily transferable. I think also you'll find people go into infectious disease and communicable disease in public health as well. I know there's been some internationally trained physicians who have worked in that area, or, you know, public health nurses, for example. Yeah, so you don't need to be a licensed doctor to do a lot of some of this work. And other ones, they may be short-term credentials, and in some institutions, they will recognize some of your credentials and make that study time shorter if you want to. For example, I can't remember if it was reading about dental hygienists or one of them where they were saying they recognize international credentials, but there's some supplement that's needed. So it's going to vary depending on the role. But the jobs, all the jobs I've shown you there, they require either a bachelor's, a master's, or equivalent education and experience. So I think the point that you're bringing is that equivalent education and experience. And for example, I know some of you are interested in data, work in the data field. So you don't necessarily have to have, you know, a master's in epidemiology. Again, you may be able to bring that experience that you have to take on a role that has to do with surveillance. So I understand there's a number of people online that have questions. So we're going to print out those questions. And then I presume we could post the answers somewhere. We could post the answers to those questions or comments.
Okay, so just to clarify, if I understand your question correctly, you are asking if internationally trained public health experts have to register here in Canada to practice. And the answer is not quite. It depends on the role that you are applying for. I don't believe that we have a centralized public health system that sort of certifies people. But like she mentioned, say you wanted to work in infection diseases, you might have to go through extra certification because IPAC is a centralized body. So you may have to you may have to apply for some certificates, but we don't have a big body that sort of registers internationally trained public health experts the way that we do for nurses and doctors and dentists and surgeons.
You got it. And again, it's my pleasure to be able to share my knowledge, and I wish you all the best. Thank you.
Thank you very much, Pegeen. Thank you. So following this, we will have presentation from one of our groups from the learning stream. Are you ready?
Yes, we are ready.
So before you could continue the presentation, I just want to quickly inform, we have a few one-on-one sessions arranged with Pegeen from 10:45, and some of you have been given the appointment. So whoever has received the appointment, please reach out to me so that we can start the consultations on time. Thank you. And now, Group 3, you can start your presentation.
Good morning, everyone. My name is Victoria Protsuk. I'm internationally educated physician, and together with my colleagues, international educated nurse Abba and international educated pharmacist Asefa, Lanra, and Omer, we went as a Group 3 from a healthcare Data Analytics Program. We want to present you today our topic, which is the quiet crisis on Canadian plates, declining fruit and vegetables intake, rising chronic disease, and a post-pandemic warning. And I want to pass the word to Landra.
Thank you, Victoria. And I'll proceed to start with the background of our data analysis. According to World Health Organization, it is recommended that we should consume approximately 400 grams of fruit and vegetable per day to promote health and reduce risk of disease. Also, the Canada Food Guide recommend having fruit and vegetable to be the largest portion of our meals. However, the modern Canadian diet is characterized by high intake of processed and ultra processed food, having a lot of sodium, sugar, and saturated fat. And we have seen also from studies by WHO, World Health Organization, that there's an association between inadequate intake of fruit and vegetables with certain diseases like obesity, hypertension, and type 2 diabetes. And these are the leading chronic diseases affecting Canadians today. Therefore, we say it is important that we monitor fruit and vegetable consumption trend in order to guide public health prioritization in Canada. So our research question is, what are the fruit and vegetable consumption trend of Canadians between 2015 and 2021? And we have 3 research objectives. The first of them is examine the association between fruit and vegetable intake and selected health conditions, obesity, hypertension, and diseases. And this is informed by the data available to us and also from the studies from WHO indicating that there's an association between fruit and vegetable and these disease conditions. Our second objective is assessing differences in consumption patterns by age, sex, and provinces to see whether there's any equality existing within these groups. And lastly, we also want to evaluate the changes over time, comparing pre-COVID era to post-COVID period. Our research methodology involved using secondary analysis of national survey data between 2015 and 2021, and we conducted a descriptive statistics and trend analysis. We used data from Statistics Canada and also the National Nutrition Indicator. The tools we use for us to analyze our data is Microsoft Excel and Cloud AI. And I'm sure you're not surprised about this because we're in this era where using AI is considered necessary for learning. The population that we focused on in our analysis is Canadian age 18 and above, and this is because we could associate that with also the data received for the chronic conditions. And the variables we considered are fruit and vegetable consumption greater than 5 times per day, BMI, obesity adjusted self-reported age 18 plus, as indicated earlier on, hypertension, and diabetes. I'll pass it on to Asifa to present the results.
Thank you, Larry, and good morning, everyone. So, all right, when we come to our presentation on the key findings, here with this graph, we can see that how the trend of fruit and vegetable consumption had been in Canada from 2015 to 2021. And we try to associate that with the most important chronic conditions, including obesity, hypertension, and diabetes. So you can see that how fruit and vegetable consumption has dropped from 2015 to 2021. And while the other chronic conditions have some kind of increase going up from 2015 to 2021. So we can see that kind of relationship or kind of pattern where there is some kind of association between this fruit and vegetable consumption and other chronic conditions. So we try to look that pattern, and we have analyzed how these fruit and vegetables do have an association or correlation with the chronic conditions, diabetes, high blood pressure, and obesity. So when you see that correlation, the strongest was the correlation between fruit and vegetable consumption versus diabetes. So that correlation is inverse, where when the fruit and vegetable consumption is decreased, the extent of diabetes has increased, and the reverse. So we found that from our analysis, and that was found to be the strongest link. And it was followed by obesity and high blood pressure. But still, it should be clear that this is just correlation, and we didn't establish cause and effect. But still, the relationship is such a strong and should not be denied. So coming to the provincial variation and pattern for fruit and vegetable consumption, we try to look fruit and vegetable consumption by province, so that we can see that there is a great extent of disparity by province. Like we have found that Quebec has the highest fruit and vegetable consumption, which is to the extent of 34%, whereas Newfoundland and Labrador has the lowest, almost much less than half of that of Quebec. So we can see that there is a variation among the provinces, and the national average seems to be almost in middle point, and that seems to be the average, whereas the Atlantic provinces are generally below the average. And again, we have also analyzed to see the pattern by gender, by sex. So we see that females do have higher consumption of fruit and vegetables than males, and that was found to be all across the provinces, and the difference is actually quite noticeable, and almost 12% for the national. The difference between females and males' fruit and vegetable consumption is found to be about 12%. That means females had higher fruits and vegetable consumption based on our analysis. And when you see this by the trend by time, so you can see that over time, both males and females show a clear decline in consumption from 2015 to 2021. Like among females, intake has dropped from 36.8% in 2015 to 24.6% in 2021. And that's also similar to that of males. The decline was from 23.1% to 17%. So in both females and males, there is a decline in fruit and vegetable consumption from 2015 to 2021. And from the picture, we can see that the decline seems to be narrowing, but still there is a concerning decline in fruit and vegetable consumption in both sexes. And when you see the national drop in fruit and vegetable consumption, taking a time point of 2017 and 2021, just 2017 as a pre-COVID time and 2021 as post-COVID time, so that we can see that there is a decline, a consistent decline from pre-COVID time and post-COVID time, and that decline was found to be about 6.5%. That was 27.3 in 2017 to that of 20.8% in 2021. So that decline was observed, and when you see this decline by province, it was almost consistent among all the provinces. So in all of them, there is a decline of fruit and vegetable consumption after the occurrence of the COVID-19 period. But still COVID-19 might not be the only factor that resulted in this difference, so that we couldn't establish causation based on this data alone. But still the pattern raises an important concern for public health and nutrition in Canada.
Okay, thank you, Asafa. My name is Umar, and I will be presenting the interpretation and key insights. Okay, so we have seen 4 insights from this finding. First one is decline in trend nationwide. So we have seen a consistent decline in fruit and vegetable intake starting from 2015 to 2021. And the other very important point is a decline in is evident across multiple population groups. Okay, so we have tried to see it based on those breakdowns, and then this is also another insight. And the other very important point is the health condition association. So there was an inverse association which was observed between the fruit and vegetable intake and chronic disease indicators. So these findings are descriptive and do not establish causality. So it's also supported by the available literature. And the third point is geographic and demographic disparities. So variation exists across provinces and sects, and difference may reflect broader contextual factors, like, for instance, environmental factors, cultural factors, though our study didn't directly measure these factors because of the unavailability of the data. And the fourth point is the COVID-19 pandemic. So the most significant decline occurred between 2017 and 2021, which is a coincidence with COVID-19 pandemic. But the real association was not explored because it was beyond the scope of this study. So finally, we concluded, based on the findings, this analysis reveals a consistent and concerning decline in fruit and vegetable consumption among adult Canadians from 2015 to 2021. And the data demonstrates an inverse relationship between the fruit and vegetable consumption and rates of chronic diseases, selected chronic diseases like obesity, hypertension, and diabetes. The other very important point is geographic disparities exist across provinces, particularly between Quebec and the Atlantic provinces. Okay, so this information may be helpful for guiding interventions. Out of that, we recommend 4 points. The first one is strengthen public health messaging to promote fruit and vegetable consumption across populations. Second point is support monitoring and surveillance of dietary trends to guide intervention and encourage nutrition screening and clinical practice considerations. And finally, align the future research with socioeconomic and environmental variables to better understand underlying drivers. Finally, despite the strength of our research, having large data sets, we have a few limitations that should be taken into account when understanding these findings. The first one is missing data. Okay, so we didn't have information about 2018 and 2019, and then because of that, it has to be understood that it was not included in the trend. And the other point is the population-based denominator. So because of the lack of the sample size for each population, we were obliged to use the population-based denominator. So this might have an impact on the precision of estimates. And the other is representativeness. Okay, we are not also certain about the representativeness of the sample. And self-reported data might be contributing for social desirability bias and that of recall bias. And finally, the cross-sectional nature of the study might contribute or affected us not to do a causality assessment. So these are the limitations that should be taken into account where we make understanding of these findings. Pass the presentation for my colleague, Abba. She will conclude on the presentation.
Thank you, Omar. On the screen now is all the links and references to our work without biases. And on behalf of our team, thank you all for your time and attention. We truly appreciate the opportunity from the organizers, Dwight, Baker, Morgan, and Karina, and all the engagements from our audience. I'm also grateful to my team for their great collaboration. Thank you once again, and we hope you find our presentation valuable. Thank you so much.
So at this time, we're now going to be moving to the profession-specific conversations. In this main room, we will have our medicine facilitators, and Saido Azam, member of our team, will be inside here to support with any challenges you may be having. For those persons who are from the nursing, dentistry profession, you will be moving to the other room next door. We will have the pharmacy breakout session or nursing and dentistry session. All right. And for those persons who are joining online, you will see the sessions labeled accordingly, and then you can pick the respective room, breakout room that you will go to. For medicine, you will be in the main conference room. All right. Thank you very much. Additionally, for those persons who are in the room for medicine, you will still have access to Wordly AI for translation. So for those persons whose English is not the first language and you may be concerned about having the information in your own language, you also have that option for translation services.
Thanks everyone online, and I'm gonna share the link for Wordly again in the chat.
So now we have our speakers, Kalpesh Kumar and Happiness, who are both online. So the floor is yours. You can go ahead. Is there any questions that you want to ask regarding the licensure process? And they'll be happy to address. So this is more like a conversation, a discussion style. So if there is any question, like in particular stage of your career, if there is any barrier that you're facing, then you can feel free to ask the questions either in person or online.
Hi, I just wanted to ask if there is any certifications recommended during my preparation for the MCQ. I'm doing it right now. So if there is any certification that I should do, I would like to know that.
Okay, so regarding Q1, I don't think you need any certification to write the exams. Although there are different study groups you could participate in, just so you can familiarize yourself with the questions, the exam format, and then I do recommend you have a lot of mocks before you actually attempt the exam, so that way you'll be able to assess what level of preparation you are, and you'll also be able to know what you can do to like improve yourself and boost your scores before you go for the exam. So I don't think you need any certifications for that.
Thank you, Happiness. Kalpesh, do you want to add anything?
Yes, so to all the doctors out there, first of all, whoever has asked the question, thank you, and thank you for having us. I think my colleague has mentioned pretty much all the required things, but I would also like to mention that during the entire CAMS journey, actually, there are no specific certificates that you collect, and it guarantees that you're going to get into the system. And as an international medical graduate or a foreign medical graduate, we all have that feeling that if we don't spend money, we will be left out and we won't be getting into system, which is a myth. You don't need to. All you have to do is build up a network, try to get into system by any means possible, and make sure you get your references. And examination score are important. When it comes to MCC QE1, Mr. Becker, Dwight Becker, is quite familiar with me, and he knows how naive I was a year ago when I came in. My resume was all over the place for the Canadian context. And starting early in terms of preparation and focusing the requirements which are needed. So reaching out to people and getting help for important steps is very important. But then the MCC QE1 is very vague from my experience, and none of the question banks are going to prepare you. You have to know the Canadian context and you have to know what they want to test. So understanding the examination format and understanding what exactly they are trying to test is very important when it comes to QE1. Everybody who is coming from medical college or having a plethora of work experience, they all know their medical stuff. But then ethical part and medical legal and screening and guidelines, all of those are very important. And probably no matter how many question bank that you will do, you might not get well prepared, or at the day of the exam, you might feel that I'm lacking confidence. So I would say Toronto Notes Essential Chapters to prepare. There is a very good book available from Dr. Felipe Santos, who helps out immensely to all of us. And he has prepared ethics content. So you can go and get that book as well. You can refer CMPA e-learning material, which in my belief personally has helped me a lot when it comes to QE1 preparation for ethics. Also, I used AI modules a lot. Now it might sound funny, but if we prompt them regularly and prepare the AI with the data that we need, like the information that we need, the more data that you will feed, the more accurate it will become. I used to use ChatGPT, OpenEvidence, and Perplexity a lot. Nowadays, there is a new AI which has come up, Cloud, which is, I believe, is more accurate. I was not using when I was preparing, but Cloud is also one of the excellent tool. But you have to know what you are asking. And you can generate the PDFs for ethical and screening and guidelines and immunization. And you can go through them. And I think that would prepare a lot. I have done 3,500 questions from ChatGPT, Perplexity, and Open Evidence generated mocks. And I personally believe that none of the question banks have helped me compared to what those AI tools have helped me. I was already anticipating the questions when I was taking my exam, what kind of questions they are putting into and what they are trying to get the answer from the candidate. So I think using it smartly and wisely will help you a lot. But CMPA e-learning, if you can get ethics books from Dr. Santos and Toronto Essential chapters like organizational and ethics medicine and psychiatry and emerge as well as family medicine, that would help you a lot. And if you go through them, I think you're good. You don't need to spend any money for any courses. You don't need to. You can use IMGA, which is free. You might have to pay $50 annual membership and you can be a part of them. ITPC is organizing weekly mocks. When the exam dates come closer, you can use them as well. And then it is an individual approach. Are you going to get benefited from studying in the group? If it suits you, you can go for it. If you feel you're going to get well off studying individually, that's up to you. I prepared myself spending hours studying individually. I didn't study in group, at least for the QE1, and that is my experience.
Thank you very much, Dr. Kalpesh. I think you have given, before we proceed, I also would like to highlight both of them are PG Y1 residents in family medicine. They just got matched this year and they are in their first year of family medicine. So they have gone through the pathway and you can see how thorough they are in the process. And I think that's a very good point, what Dr. Kalpesh mentioned about using the tools that what we have instead of spending a lot of money, which is something very essential for most of our INGs. Because like mentioned earlier, we are going through a lot of complex life journeys. It's not just, most times, it's not just you, it's also your family who's here. So it can be an expensive process and that can become overwhelming. So using the open resources as much as possible is going to be very beneficial. Thank you so much for sharing that. There are some questions on the online chat as well. We will get into that.
Good morning. My name is Arlenis Rivera. I'm international medical graduate from Dominican Republic. My question is, which things or skills are really important in CARMS? Maybe the year of graduation, if it's too long, how I can improve that. My year of graduation, for example, is 2019. And I'm thinking to go back home maybe to improve, like to reduce my gap. If you have any advices, I will be grateful. And congratulations for your match.
Thank you so much, Doctor. And I think that's a reasonable thoughts that you're already putting into the process that you are preparing for. Now, there is no blueprint from what I have seen and from what I have experienced myself. To make you feel a little better, my year of graduation is 2010. And if I can get in, probably anyone can get in. And I'm not the smartest person in this room. I'm an average medical graduate with years of experience. But again, as I was telling, understanding how it works, reaching out to people, getting help when needed, and preparing towards that is going to be very important. Now, if you have a recency of practice within last 3 years, you should not be worried about when it comes to CAMS or associate physician role or even clinical assistant or practice ready assessment role. As long as you have a recency of practice within last 3 years, you're good to apply anywhere. If you don't have that, then you might be thinking in a right direction, going back where you can practice medicine for at least 3 to 6 months. And that will update your recency of practice for another 3 years. And that will help you a lot. Now, why recency of practice matters a lot? For an example, when we get into medicine and when we start practicing, even as a clinician, we have to update our ACLS or BLS every few years. And the reason is, as a human being, we tend to forget. If we don't do it, we tend to forget. even in those 2 years, how many crash calls or medical emergency calls that we attend? Probably not many. And the reason they ask us to update that is because we can get familiar and we can stimulate the exact process which can happen in real. So in case if something happens, you are well prepared. Similarly, when it comes to recency of practice, Canadian Institute and Faculty of Medicine wants to know whether or not you are well prepared to come into the system. Now, everybody will take time to adjust. Even if we change house, it might take a couple of weeks before we get familiar with the settings. But imagine you are coming from completely different system into new healthcare system. They put a lot of emphasis on recency of practice, thinking if you have been clinically active in last 3 years, you are more likely to get adapted to the system compared to someone who has not practiced medicine for 5 years or more, because then you lose the grip when it comes to practicing medicine. If I talk about myself as well, like I've been clinically active for years and years, but when I came here last year in Canada and I was not working for 3 months, I was filling that void and I was worried that I will probably lose that age of having that connection with the patients. So that is very important. So answering your question, if you have a recency of practice in last 3 years, you don't need to worry about. If you don't have, focus on your exams. And once you are done with your QE1 and NEC, you will have at least, let's say for example, you're taking NEC exam in May, which is probably in a day or two. I don't think you're taking tomorrow, otherwise you would not be here. But let's say you're taking in September, and by the time your results arrive, you will have a CAMS window open. But you still have 5 to 6 months until you get your interview. So you can go back home, you can continue your licensing application through CAMS while being clinically active. So by the time when you appear for the interview, you have that in your hand that even though I was here until so and so time, now I'm already into the system, clinically active, working to update my recency. So you can convince them even in your interview that they can take you into the system probably earlier. So that is something I would advise. But then again, it depends on circumstances. Some of them have families, some of them have children going into the school already here. So I don't know what is your situation, but you have to think, you have to sit down with your family. During this journey, you might have to sacrifice for a few months along the way to get into the system. But it all depends on circumstances. If you can manage that, excellent. You can go and update your recency of practice.
Okay, so in addition to what Dr. Kapesh Kumar said, let me just share my own experience of what I did. Because I arrived in Canada 2023, I wrote my exams 2024. So before I applied for CAMS, I realized that my recency was running out. So I started looking into other things I could do. So firstly, the clinical assistant pathway, that is working as a clinical assistant, also helps your application for CAMS and also keeps you still clinically sound because you get to interact with patients. So I took up a role as a clinical assistant. In addition to that too, I also wanted to gain more experience in family medicine. So I took up observation role. So thereby I was going to some family medicine clinic where I was an observer there, and at the same time I also acted as a scribe in those clinic. So these are all things that can boost your application and help your application for when it comes to recency. From my understanding, on licensed clinical assistants from other provinces like BC, Manitoba, I think they count as recency. So it depends on the province you're coming from. Also, in addition to all of these, I also participated actively in a lot of conferences, CPD programs, and all of these were educational activities that I participated in just so I can stay recent and up to date with the current medical guidelines. So these are all some things you can do in your free time. Also depending on what works for you, because some of these could cost you financially. So you have to just like strategize and make decisions that will work for you and that will be able to help build your resume.
Thank you, Happiness, and thank you, Kalpesh. There are very incredibly two aspects of the possibilities. So thank you for sharing that information. I just, while you were speaking, Happiness, I just wanted to clarify one thing. When you talked about clinical assistant programs, are these one of the registered programs that are seen in Alberta, or is it any
physician assistant jobs or clinical assistant jobs, like for example in Ontario?
So the Ontario one, because it's unlicensed, so it's not recognized as a recency of practice. But for the licensed one in Alberta, BC, I know it's recognized as recency. So that's the difference here. But I know that it still gives you a little bit of an edge because I was working as an unlicensed clinical assistant in Ontario, and I believe it helped my application. That's just my belief.
To add something on these licensed and unlicensed clinical assistant roles. A lot, as I was telling, a lot will depend on the individual circumstances. I'm in Ontario and I was doing unlicensed clinical assistant role similar to Dr. Happiness. And I was doing with both the family medicine clinic as well as pain clinics. And that's really helped me getting really strong references. So you might not get paid handsome. You might be working way level below what you're doing back home or wherever you are coming from. But I think getting exposed into the system and getting really strong references is going to be key for your comms application. So wherever you are going to go and work as a clinical assistant, if it is unlicensed, make sure you get the good vibe from the physician or the healthcare professional that you're going to spend time working with. Even if it is unpaid, fair enough, but if you get a really strong references working there for 3 months, that is going to help you a lot in a long run when it comes to comms application. Now, coming to the licensed clinical assistant or associate physician role. So every province has different nomenclature. BC has associate physician, Alberta has associate physician, but when you go to Nova Scotia or when you go to Manitoba, you will have clinical assistant. Essentially same, not the physician assistant. Physician assistant is completely different, where you have to go to the college and attend 2 years of course in order to get a certified licensed physician assistant registration, which is different. Clinical assistant or associate physician is something where we can work as an assistant. Now, I would say for every province, go through the website and read about it. Because when it comes to Manitoba or when it comes to Nova Scotia, you will be spending $400 to $500 through physician applied or CA account just to get the license even before you apply for the job. And there is no guarantee whether or not you're going to get the job or not. When it comes to BC, forget about, do not put a single penny from your basket into BC. There are no jobs available when it comes to associate physician for the past year or so. I have even reached out to the person who is looking after, and I would clearly told them on Health Match BC that why are you even having this role when you don't have a job available on your job board? So do not spend single penny. Do not waste your time looking at the BC associate physician role. And BC is very difficult even for volunteership. You have to go through the license and documentation and police clearance certificate even just to get the volunteer role. I would say from my personal experience, even before the CAMS application interview started, I actually applied for Alberta Health Service Associate Physician role. The reason I'm focusing more on Alberta from the personal experience is because all you have to do is get the Alberta pre-screening eligibility letter. So what you have to do, you have to fill out the form, you have to share your document from physicianapplied.ca. You don't have to spend single penny. All you have to do is get your pre-screening eligibility letter. Once you get that letter, you'll be able to create an account on AHS and you can apply for the job. And you can start getting interview. It might take 4 weeks to 6 weeks time, but you will probably get an interview. There are plenty of jobs available. I got the job. I got the secure job as an associate physician in Royal Alexandra Hospital in General Internal Medicine in Alberta. And that was in December. But then I was waiting for my interviews. So I spoke to them and they are really kind. I spoke to them and I said, I would want to delay my starting date until March because I want to wait for my CAMS first iteration outcome. And they were very happy. They said, all right, we understand this is very important. Keep taking intake of associate physician every 2 years, every 2 weeks. So they said by the 4th of March, if you don't know or if you don't get in, come back to us, get your registration done. You can start from 23rd of March. So I was already securing my associate physician role before knowing the CAMS outcome. So I would say Alberta, focus on Alberta pretty good. Nova Scotia, you can spend some money, but which is around 450 or something. But I think there are plenty of jobs in Nova Scotia, and I would say you would get into it. Even Manitoba, there are plenty of jobs available. And Manitoba, from what I have been told, I haven't worked there, but what I have been told is Manitoba has better work-life balance as a clinical assistant compared to Alberta as an associate physician. And even the pay is better compared to Alberta. And maybe the cost of living and the tax is probably less compared to Alberta. So if you are willing to move and willing to work as a licensed clinical assistant, Manitoba, Nova Scotia, or Alberta is something you can put your money on. And I think within 6 to 8 weeks' time, if you have your language exam cleared, and if you have NAC or QE1 cleared, you can absolutely try that. Again, there is a very good book available on MCC website from Dr. Felipe Santos about all the associate physician and clinical assistant roles as per the province, whether or not you are eligible, what exam you require, what exam you don't require, whether or not you need language requirement, and also for practice ready assessment as well. All the information available. So you can definitely go through that. Worth read. You don't need to read the entire book. There are specific section on in that book where you can focus and you can apply for one of these roles while you are preparing for the CAMS. And if CAMS happen, excellent, you can move and start your practice, start your residency.
Thank you so much, Dr. Kalpesh and Dr. Happiness. And this is where like the lived experience makes an important contribution here. The information we see online is one thing, but the reality can be different. And it can be evident through people who have gone through the system. That's why it's very important to continue conversations with doctors like Dr. Kalpesh, Dr. Happiness, and other residents who have been able to go through the CAMS process, because they will know each and every pitfalls and they would have had their own experiences. So which is important for us to know to make informed decisions. So thank you so much for that very informative answer, Dr. Kalpesh. And also Dr. Happiness. These are these are going to be very helpful. And we have one question from Grace from the online participants. How long did it take you to get to the residency matching? Could you also get into the details of the tips, how you prepared for the exams, like how your days were structured? And also, could you talk about the financial side of your pathway, like how much money did you spend on your preparation and sitting for your exams? I believe you did cover a few parts of it, but if you could give more insights on this, I think it will be very helpful. Thank you.
For these questions, I would say to answer your first question, how long did it take you to get to the residency matching? I came here last year in February 2025, so probably a year plus couple of months, and I got into the residency. The pathway differs for people. There is no blueprint again, and it does not work out for everyone what worked out for me, and it doesn't work out for me what worked out for other. You have to make your own journey and you have to lay out a plan depending on your own circumstances and where you are in terms of your exams and in terms of your family and financial circumstances as well. I came from Australia, and even before I landed, I was coming with a mindset that I'm not going to get any job for a year or two until I get into residency. So I came with enough financial background which would take me through this journey. But I understand it can be brutal, and you have to forget all your past privileges and start from the scratch, being humble enough. And the reason I'm doing this today is purely because of IEHP. I was lost when I came in here. I didn't know anyone. I don't have any family contact who can help me within this CAMS journey or Canadian healthcare integration. And I was just reaching out, sending cold mails and messages on each and every platform like Instagram and LinkedIn and Facebook, and then reaching out to people like Dwight, who has helped me immensely from day one with regards to my resume, as well as how to make a contact or build up the network. And you would not believe, but I got the job as a clinical assistant, which is unlicensed, in the pain clinic through one of my contacts on Reddit. And I was speaking with the doctor who has matched and he is going to start his second year of residency this year. He matched the year I came into the Canada. And I was speaking with him while I was in Australia through Reddit, and I was constantly in touch. He has never shared his contact until I came and I was speaking again about job, and he said, "Hey, I matched into the residency and I have a vacant place at the pain clinic where I work. Would you like to go and speak with them?" And that's how I got my job. So you never know. So reach out to as many people as possible is something I would say. I even used to joke, like people nowadays who know me, they ask me, "How do you know so many people?" And I'm like, I don't have any self respect. I just reach out, you know. But I would say it's very important to build up a network which will help you a lot. And each and everyone have a good thing to share. There is a lot of negativity. Switch off from them. You need to know who is going to help, who is not going to help. Switch off from all the negativity and negative people, and try to get in touch with all these people who are going to be as helpful as possible. So that's your first question. How long will it take? It depends on how fast you do your exams and how ready you are when it comes to comms. I know half a dozen of doctors who were preparing with me for exam, but by the time the comms application started, they just gave up. It was so overwhelming. Exams, when you will do your exams and when you will start your comms application, you will probably laugh at yourself saying why I was so worried and dreadful about my exams. That was the easiest steps. Comms can be brutal, very demanding, and you have to juggle on so many fronts. So be very, like I would say, be mentally prepared, talk to people, reach out to people, speak to your family, be kind on yourself. But once you're done with your exam, focus on your comms, and as fast as you can go into get into the comms, likely are the chances that you will be into residency sooner. The more time you will take, the difficult it will get, is what I can tell, because the recency of practice is very important. Let's say you don't get into this year, then you are probably going to wait until next year. So your recency of practice, if you're still in Canada and if you're not into the system working as a licensed clinical assistant or an associate physician, your recency of practice is going to get bigger and bigger. Even when it comes to CAMS, associate physician and clinical assistant role, which are licensed in other provinces, are not updating your recency of practice unless you're applying for practice ready assessment. That will put a lot of value when it comes to your application, but it doesn't count on your recency of practice. So go through your exams as soon as possible. And exam is never about knowledge. It is all about preparation, which is where I'm going to answer the second question, that can you go into details about how you prepared? Again, it depends on where you're coming from. My background is completely different. I've done a lot of exams in UK, in Australia. I've done USMLE in the past as well. So it all depends on where you're coming from, how well prepared you are, what is the base of the medicine knowledge when it comes to exam, and then understanding the format. As I was telling earlier, Canadian exam, a lot of people will ask on social media, "Hey doc, I'm doing UWorld. Is it enough?" When it comes to medical knowledge, if you have enough time, excellent source of knowledge when UWorld is. But when it comes to medical exams, MCCQE, which is probably a lot different from all the exams that I've done in the past, they focus a lot. 35% of the exam content would be your public health, family medicine, because that's what they expect us to be in. The level is they are trying to check us on a level where the medical student is coming out of the med school as a graduate and now trying to get into postgraduate, right? So they will focus on family medicine, psychiatry, ethics, organizational medicine, also medical legal aspect, and also public health screening, guidelines, and immunization. Very important. So focus a lot on this subject as much as you focus on your medicine subject. So again, it depends. It took me about 8 weeks before I wrote my QE1. So if you feel that you have a very good base and you have done a lot of other exams, you probably need 6 to 8 weeks and you're good to go. If you feel you might need more, maybe 3 to 4 months is more than enough and you're good to go. You can spend 4 to 5 hours every day, and as the exam comes nearby, you can spend longer and longer hours. And for the last month, the plan is to do as many mocks as Dr. Happiness was telling. And just while you're doing mock, just don't do it for the sake of it. Focus on the pattern. When you go through, when you review your mock, and when you go through, uh, find out which area where you are struggling, which subject you are struggling, and then prompt AI and make a file. Like when I was doing my preparation, I found out that endocrine is something where I was struggling. I found out that OBGYN, mainly obstetrics part, is where I was struggling. So what I did, I prompted AI and I made the PDF file of quick revision. So I would go through them quickly, revising when the exam comes nearby. So I know at the top of my mind that this is something I need to do if the question comes from this. So focus on the preparation in a way where you don't revise all the question banks again and again. I only did UWorld once. I did 20% of Canada Q Bank and I did 15% of Q Bank. And then I did 10 essential chapters of Toronto notes, but I was doing a lot of mocks. I was doing MCC papers as well, and I found out areas where I was struggling and I put all my money into it, not revising things that I already knew. And visualize. Manifestation is very important. A lot of people, I know one of my friends who was studying for QE1 got really overwhelmed, went to the ER because he could not sleep, took lorazepam on the day of exams. She was blunt, just staring the screen, could not do, failed her exams. She passed her NACOSKI, excellent score. She failed QE1 just because she was overwhelmed. So be calm, don't be your own enemy. Be consistent, show up, sacrifice. I was not even speaking with my mom and dad. I told them, if you have any medical emergency, call me. Otherwise, we don't need to talk. As long as you're not calling me, I know you are alive. Let me do my thing. I was spending 12 to 14 hours for the last 4 weeks in the library. Dwight knows I was even going through my resume while I was sitting in the library when I was doing my resume as well. So I would say sacrifices are important. I forgot. I love soccer games. I did not even watch any single soccer game for those 4 to 6 weeks. Champions League final was going on. I was like, fair enough. I'll watch it on a repeat. I need to focus on my exam. So you have to know what you need to do, and if you can do it, excellent. You can go through it. I know people who have done their exams within 2 weeks' time, both QE1 and NACOSKI in September, remarkably well scored that they have got in their exam. So it all depends on your circumstances, right? NACOSKI, there are plenty of tutors available, expensive courses. Again, it depends on your financial circumstances and your preparedness. If you feel you are well prepared and you have been clinically active all your life, you don't need to go through any paid courses. If you feel you might get some help and you are financially sound, you might want to spend. There are plenty of people. I don't want to advertise someone, but research yourselves, reach out to your people or doctors who have gone through this process and put your money wisely, because you will find so many of them. There are people who are taking NACOSKI mock, running NACOSKI course, still not into the system, 5 years being into Canada. So you don't want to go through for the sake of it, thinking if I'm going to spend my money, I'm going to score well. No, it does not guarantee. I have not paid a single penny when it comes to NACOSKI. What I did was, I used to wake up 5 in the morning from 5 to 8. Every day I used to practice with different candidates. And I had 40 people with whom I was practicing. Every person, every day, different doctor. Why? I did not want to be comfortable practicing with the same person. And everybody is going to be a different SP. Everybody is going to give different feedback. And everybody is going to teach you different things. That's why reach out again. Build up a network, practice with as many people as possible. Sometimes just listening and learning passively is going to prepare you well rather than reading Edmonton manual or reading some NACOSKI book. So practice, practice, and practice is going to be very important for your NACOSKI. Now, financial aspect, there are plenty of help available. IEHP is one of the organizations who can help when it comes to applying for the loan from the banks while you are preparing for the exam. My circumstances were different. I worked so many hours, extra hours before coming here in Canada while I was a registrar in internal medicine in Australia. And the pay is pretty good, so I did not really require as much financial support while I was going through it. But there are plenty of support available. Reach out to it. There is an Ontario Student Application Program as well. If you are not making more than $16,800 a year, you can apply for OSEP program. You can do 2 years of master's program, and you will get around 36,000 grant plus loan of 26,000 or so. These are tentative numbers. Don't take anything for granted, please. But what happens with OSEP program? Our premier has changed some of the rules, so the grant that we get might be different from what people were getting a year or two ago. But you can get grant, which you will keep it to yourself, which you can use for your exam, and you have to pay loan. If your course is 2 years, then means if you're starting your course, let's say 2026 September, you're going to finish your course in 2028 September, and you will be paying from December of 2028. By the time, if everything falls in right place, like I have been lucky enough to get into system, you might match, you might start earning, you don't need second year of OSEP grant, and you can give up and you can pay back your loan in 2 to 5 years time. So there are plenty of support when it comes to finance available. Go through them, speak to IEHP, they will be able to guide. Reach out to OSEP application advisor or directly to OSEP or financial aid office of the program that you want to get into. They will help you at each and every step, and you will be able to go through this process smoothly without having to worry a lot about. And obviously, if you're in Ontario and if you want to work as an unlicensed clinical assistant, find out family doctors nearby or specialist clinic nearby. Go there directly in person. Leave your resume to the secretary or receptionist. They might call you. You might have to go to 10 different clinics, and one day you get a job from 3 different places. I was looking for job for 3 months. Did not have anything. Just before 2 weeks of my QE1 date, I received 3 calls on the same day saying, hey, we are happy to offer you job. I didn't have license here, I didn't have car, but I was like, okay, I will study while taking the bus and I will start working because I didn't want to lose that opportunity. So I started going by bus to the workplaces. I live in Markham at the moment, but I was going to Newmarket, I was going to Oshawa, I was going to Vaughan. It took me 5 to 6 hours coming back and forth, but I was doing 100 questions in that time. So use your time wisely. There will be obstacles, there will be barriers. It depends on where you want to put your eggs in, which basket. And if you can manage that, you are going to go through this well. And visualize, manifestation is very important. Every time I used to get overwhelmed or anxious about my comms and my application, I used to visualize telling myself that this is brutal, this is difficult, but come March 4th, 2026, I am matching into my first choice and the first call I'm making to my mom, and that is the day I'm going to cry. Until then, I'm not going to cry. And that is exactly what happened. You will feel anxious. You will feel hopeless. You will get lost during this journey. Be persistent, consistent, show up, and exactly it will happen. When it comes to QE1, I'm not taking much time, just a couple of minutes. When it came to QE1, I was manifesting. I don't know if you guys are a part of CCSYR, which is an excellent organization as well, which helps candidate without taking any penny. And there is a doctor, Dr. Guillermo, who helps so many candidates. And I used to talk with him. And he kept telling me, manifest, manifest. And I used to manifest a lot. And I used to manifest 3-digit score of my QE1. And then come a week before the exam score was about to release, they changed the criteria and they said now instead of out of 400, you're going to get your score out of 600. So I was even texting Dr. G that, hey, Dr. G, I was manifesting the score. Now the criteria has changed. If the manifestation come true, I'm going to fail this exam. I switched my mind for the last week or two, and I was manifesting, okay, keep the percentile same, but the 3-digit score now should be so and so. And I'm telling you, I'm not exaggerating. My score was exactly same 3-digit which I was manifesting throughout the time when the score got released for my QE1. So visualization, being positive, being kind on yourself, working out, exercising, spending time with family, very important. You have to sacrifice, but you also have to be kind on you because this journey is brutal. And what works for me is not going to work for you. What works for you is not going to work for me. So do not look at someone else and think, oh my God, this doctor has already got into the residency. He must be brilliant. No, he must be lucky. He was there in the right place at the right time, getting help from the right people. And that's why he's there or she's there. Your circumstances are your own. Show up to yourself and go through this. You are absolutely going to start your residency come next 2027 July. And we might be together. You never know.
Thank you so much for sharing your journey. And it just shows how much you were dedicated and how sincere you were throughout the journey. Like, you were persistent. And that is very important. That is something that we all as IMGs need, because at one point in time, we break down at something, we get overwhelmed. And then that is one of the main barriers, right? So being persistent on the journey is very important. I would like to reflect on something that I've read recently. It's on Substack. So it's about luck. You know, luck doesn't just come. You need to open as many opportunities as possible. He found a mentor in Reddit. You know, he found a contact in Reddit, and that was amazing. Like, so reaching out to more and more people, getting in touch, networking with people, getting as much information as possible. Very important. Their stories are inspiration for us. Like, every time we get overwhelmed, I feel like it is important to get in touch with someone who has gone through that process and who has been able to successfully match. We get a lot of negative reviews from people who have not been able to do that. They are also in the same journey as ours. So we need to reach out to people who have gone through the path and try to get information from them, which can help us. So I also, when you were talking about the pathways, Dr. Kalpesh, I wanted to follow up with one question. If you have any more questions, I can follow up. Oh, okay. So I just have one question. I had a question as well. You did mention you were a registered doctor in internal medicine in Australia. So were you able to transfer your credentials here in Canada, like through the approved jurisdiction route, or that was not among the approved jurisdictions, so you had to go through another process?
Yes. So thank you for asking this question. So what I was doing in Australia was a non-training role. So it was not a training. I was doing a non-training internal medicine registrar role. So when you are not doing training, or when you have not completed your training, you cannot transfer it to the next jurisdiction. So if circumstances are different, I have got my very close friend coming just in September, next September. Now he has completed his GP training, MRC GP in UK, and he is coming here directly, and he is going to work as a family physician with the provisional license without writing any exam. All he has to do once he comes here and starts practicing as a family physician under provisional license, he will have to write his QE1 if he wants to get his full licensure within a certain period of time. Otherwise, he will be working as a family physician under provisional for 5 years. So if you have completed your training in any field of medicine or as a family physician, if you have completed your training, then you can transfer your training into the jurisdiction. Different provinces have different rules. But again, Dr. Felipe Santos is one of the best resources for us. He has a lot of sessions for specialty route as well, which is known as PER, practice eligibility route. So someone who has completed the training in internal medicine, different fields, or family medicine, or PEDS, or OBGYN, or psych, they can directly get into it through PER. They probably might not need to write all these exams or go through COMS. My circumstances were different. Though I have worked in different countries, anywhere, that was another red flag which I was worried about. Because in my interview, they might be asking, hey, you've been to UK, you've been to Australia, you worked in India, you haven't stayed anywhere consistently. Why you did not complete your training? What was the reason you are changing your places from places? And what is the guarantee you're going to commit your 2 years of residence, your 3 years of residency here in Canada if we take you in? And what is the guarantee once you come out of the residency, you're going to stay here and not leave, right? So that is what I was worried about. But I did not complete my training in UK. In Australia, I was doing non-training role. before I moved here. And that is the reason I had to go through CAMS or practice ready assessment route. So again, it depends on circumstances. If somebody has completed the training, probably you might not need CAMS. You can directly go through practice eligibility route.
Thank you so much for that, Dr. Kalpesh. We have another question here.
Good morning, I'm Stephanie. Thank you, Dr. Kalpesh. I want explanation on the Manitoba licensed clinical assistant role. You mentioned about the process is through a payment process. Would you advise paying for the license before securing a job, or wait to secure a job before you apply for the license?
Hi, Dr. Stephanie. Thank you for this question. So I've reached out to people over there via email and text, and they said you are eligible, but then they gave me two options. Either you can apply for the CPSM, College of Physician and Surgeon of Manitoba, clinical assistant license first before you get the job, or you try to secure the job and then you apply for the license. They also told me that if you get the license, which comes with the provision or probation, certain duration, and in that period, which is like 6 months, if I'm not wrong, in that period, if you're not able to secure the job, you might have to renew that. So that's another process where you have to spend another $300 to $400. And that is the reason I was focusing more on Alberta, because it is brutal and there is no guarantee whether or not you're going to secure the job, right? And also, I did not want to spend money. So I thought Alberta would be a great, because I will secure the job first and then I'll apply for the license. But it all depends on you. If you feel that $400 or $500 is not a big deal during this journey for me, and I'm happy to apply for the license, fair enough, you can go for it. You will have to go through physicianapply.ca, where you can apply the new registration. There is a column on your left-hand side. I would say personally, if I have to tell you, go through the Manitoba's website, CPSM website. There are different options available. Read about it and try to secure the job first. Once you get the interview, and if you feel that you have got the job, if you have secured the job, then only apply for the CPSM. Why would you spend $300, $400 before getting the job? And also, in addition to this, Manitoba also has an LMP IMG stream, which is a 1 year of LMP IMG fellowship kind of program, where you can do that. And after that, you can get into family medicine practice ready. So read about that as well. Manitoba has different pathways. If you feel you are practice ready eligible, you can directly apply for family medicine PRA. I think it opens twice a year. So have a look on it. The last time it was open was in February. I think next window is going to open in September, which would be the CAMS time. So just have a look on it and make sure you are well prepared to apply. Also for the Nova Scotia, if one of you are eligible for practice ready, Nova Scotia has two programs. One is hospitalist, excellent program. I applied for it, but then I closed out because I got meshed into CAMS. But practice ready, Nova Scotia PACE program, it has a hospitalist pathway, and it also has an office-based family medicine pathway as well. So if you have a recency of practice with the language criteria that you are meeting, I would say go for it, apply for it. That would be a great exposure, and you get into it and you get paid good money as well. And then later, after completing your practice ready, if you still feel that maybe a CAMS would be a great, you can still go into the CAMS, changing your field as well. That is my answer to your question. Manitoba, to summarize, I would say secure the job before applying, because you don't want to spend money. There are so many licenses, so many exams that you have to do. Even after you are done with both of your licensing exam, you might want to do BC CAP, for which you have to pay the application fee. Then you will have MMI, which is free if you get invited. But then you have to do your CASPER, you have to do your FM Pro C, and you have to do Alberta's application as well. If you're in Alberta and you're applying for the Alberta's residency, you have to do AIPMG as well, I guess. So there are so many exams that you would do, and your language exam as well, if you have to. So make sure you are not spending money just for the sake of it. Use your finances wisely and optimize the results in your favor wherever you want to apply for.
Thank you very much. I think I'll pass the mic on to you so that you can also tell it to the people who are online so that they can hear it from you.
Hi, my name is Rianne. I just wanted to clarify between the licensed clinical assistant roles versus unlicensed. The licensed clinical roles in Manitoba, Alberta, you need to have some sort of exam completion, whether it's the NAC or the QE1, versus unlicensed clinical assistant roles in Ontario. You can start working in those fields without necessarily having completion of the exams. So just to differentiate between the two.
Thank you very much. Is there any more question here in person or online? To both Dr. Kalpesh and Dr. Happiness, is there like one final message that you would like to share it with the participants here, that one mantra that has helped you so much that
I
they
have
can
another
carry on?
question, sorry. I would like to thank Dr. Kalpesh and Dr. Happiness for for the time that you put in this. And one final question is, it's been for my story, it's been a long time without working in a licensed role, and I am in Ontario. I was wondering, would you recommend someone to go back to school and redo medical school, or because it's been a while, and you mentioned that having a license, like at least 3 years, it's get easier. So for someone who doesn't have that, what would you recommend?
Just one thing to clarify from your question, Grace. When you talk about going back to med school, are you talking about going to med school here or going to one back home?
It's going to med school here.
Here, okay.
Hi, Dr. Grace. Thank you for this question. So I just want to clarify, you are already a doctor, right? You completed your medical school.
Back home, yes.
Okay. Then I don't think you have to go and redo your medical school, but instead, you can go to the country where you are licensed to practice as a physician and work either in family settings or emergency setting or in any hospital settings, which will update your recency. You don't need to do the medical school. I know a doctor who has matched into my program this year, and he was working in an IT for the last 6 years. And before that, he was not having any job for a year. So he was away from the clinical practice for 7 years. And last year, when he got laid off, he decided to take both the exams and apply for the CAMS. And that was his first time applying for the CAMS. And he got matched. To answer your question, I think I would say if you are committing your future practice as a physician in Canada, get your exams out of the way. Very important. And while you're done with your exams and applying for the CAMS, maybe you can go back to the place where you can practice and update your recency of practice. You don't need to redo medical school, and you don't need to go and update your recency of practice before taking your exam, because you do your recency of practice, you update it, and then you take another 3 years to take your exams. You might have to go and redo it again because they usually consider 3 years, within 3 years, right? But then again, as I'm telling, it all depends your previous background as well. The doctor that I was just speaking about, he has an amazing experience working as a primary care physician, working in an emerge, working in different healthcare for years before he moved to Canada and started working in IT. His age is 45 almost. So it all depends on your circumstances and your resume and your references and your exam scores for the CAMS in order for you to get matched. So recency of practice is very important, but if you just update that and you don't have strong references, or you don't have a great interview skills, or you don't have great scores, maybe you might not get considered, right? So you have to balance your application in a way that, for example, at least you are being considered. So you have to balance it in a way. For example, let's say your scores are not really excellent, then you might have to compensate doing your APEM-PRO-C and CASPER with an excellent score along with great references and maybe an update in your recency of practice. But if your exam scores are excellent and you have great references, then you can still get away with average APEM-PRO-C and CASPER score and recency of practice, even though it is 3 years, as long as you can justify what you were doing while you were not clinically active, you can still get an interview and you can still get selected for the program. So it all depends, right? And again, as I have been telling, and I tell all these people that there is no blueprint. It is also a luck as well, because just because I have matched this year doesn't mean that I was the brilliant candidate. I know personally at least half a dozen candidates who had an excellent profile, an excellent resume, and still did not match. I know my friend who is in US, amazing scores in both the steps, excellent candidate. Every year he used to get interview, 3 or 4 or 5. He never matched for 3 straight years. So he's slowed down, he reflected, he's got into touch with professional people and behavioral psychologists and started preparing for the next cycle, focusing on his interview skill. And this year he got matched into internal medicine. So he was probably lacking in his interview skill and not anywhere in his application. So your application is going to earn you an interview. But then how well you do in your interview is also going to be very important. So it all depends. And at the end of the day, it also depends on someone who is reviewing your interview or application. You can control your circumstances, but at the end of the day, the other person, on the other hand, has to like you or me. And they have to have that vibe or gut feeling that I want to work with this doctor, I want to take him in my program or take her in my program. So it also depends on luck as well, right? So you do what you can control, and then rest is up to your God. If you believe in, if not, then rest is up to destiny.
Yes, definitely. It's very important to stay focused and, trust in the process and give everything what we can realistically do. Thank you so much for sharing that. So before we wrap up, I just wanted to ask, like I mentioned earlier, one mantra that helped you. Could you just share it with our audience very briefly? Like if they have to take home one message from you, what will that be? Both Dr. Kalpesh and Dr. Happiness, please.
I think I was telling that already during my talk, that reach out to people. Building network is very important, and try to establish as many connections with the physicians who are already into the system, and be persistent. And I would say, if the finance permits, get done with your exams as fast as possible. I see plenty of people delaying their exams, thinking, oh, I'm not prepared, or maybe I need better score, or okay, this time I'll just take a break and I'll do it next cycle. No, sacrifice couple of months to 4 months, get done with your exams. Once you're done with your exams, you have plethora of opportunities. So many windows are going to get open, and one way or other, you are going to get into system.
Thank you so much, Dr. Kalpesh. And Dr. Happiness, would you like to add something?
In addition to what Dr. Kapesh said, always remember to take care of yourself at each phase and state or stage you are. Especially if you write the Q1 exam, relax maybe a day or two, then pick up the next phase. So that way, by the time you're getting to the CAMS level, you're emotionally, physically, and mentally ready for the CAMS stage. The CAMS could be stressful, but if you have the good information you need, if you're able to like strategize, plan at each phase, I think you should be able to like go through it easily. So another thing is always ask questions. Like, don't be shy to ask questions, because that's how you get information. That's how you know what to do, and that will save you a lot of effort and time. So through the informations, you can plan yourself strategically. Should you apply and should maybe you did not match, that's not the end of the world. That does not mean you're a lesser doctor. No, what you have to do is take a break, recover, look through your portfolio, try and see, okay, where can I improve, what can I do to improve my eligibility and also to improve my application, and then you plan towards that. When it's time for the interview preparation, please practice very well for the interview preparation. Your dress code, how you smile, the camera, what you say, you need to practice very well, and you need to put a lot of effort into this, because the interview is how you present yourself, how you show them your skills, because the CV, the personal statement has gotten you there. So the interview is where you get to shine and sell yourself. And in order to do this, you have to look at all the factors and you have to prepare very well. So just in summary, take things one step at a time and don't be so overwhelmed. That's all.
Thank you so much, Dr. Happiness. That really is helpful. Thank you. So that's a wrap for our session on discussion about the licensure pathways on medicine. And thank you so much. I really would like to, again, thank Dr. Kalpesh and Dr. Happiness for sharing the time and expertise with us today. And thank you for everybody who wanted to ask questions and clarify. Definitely it added to the conversation and definitely would have helped someone like an extra little nugget for today. Thank you. And so now the lunch will be served. But before moving on, a couple of points based on the discussion today. I would also like, some of us mentioned about the financial assistance offered during your exam preparation and career progression. We have our community partner, ACHEV, who also has a booth outside. So they do offer some services helping internationally educated health professionals with some financial support. So you can reach out to them as well. And for people who want to prepare for the QE1 exam for a paid service, we also had Dr. Mark, I'm not sure, maybe he's outside networking, also join us from Med School Reviews. So he has also been a very good mentor for many of our mentees who gone through the QE1 exam. His program is a paid program, but he does offer services if you would like to reach out. So, and also a couple of more points before we proceed. For everybody who participated in the event today, as I mentioned, this is a part of a series of pre-conference leading to the conference at Pegasus. So for everyone who participated today, like after the event at 4:30, you can participate if you'd like to for a walking tour of the University of Waterloo, or for a short film view and discussion. It's about a movie called A Dream Called Kushi in Balshali School of International Affairs. So that is some nugget that I wanted to share. Okay, so the lunch is served, so you can please join for the lunch, and we can convene back at 1 for the learning stream presentations. Thank you.
National averages may suggest stability, but provincial data show a more complex picture. Some provinces have HSMR value above 100 baseline, means their observed mortality is higher than expected. There are three important points here we should mention. First, there is objective HSMR divergence, meaning some provinces differ clearly from the national benchmark. Second, there is a clinical shift during the COVID era period from 2020 to 2025. Higher mortality appears connected to a specific clinical condition and system pressure, not just random variation. Third is a recovery gap. The data suggests that health system recovery after the pandemic did not happen equally across Canada. This matters. Why? Because persistent HSMR differences can help identify where clinical pathway quality improvement and targeted support are most needed. To understand the issue, we need to understand the HSMR baseline. HSMR is designed around 100. A value of 100 means that observed mortality is equal to expected mortality. If HSMR is below 100, mortality is lower than expected. If HSMR above 100, mortality is higher than expected. So the issue is not only whether mortality exists, but why some provinces remain above the expected threshold. This slide highlights three parts. First, the 100 baseline act as anchor. Second, diagnostic drivers such as sepsis, pneumonia may help explain why some areas higher HSMR. Third one, there is an analytical need to connect COVID era community trends with an hospital across provinces. So the baseline gives us the reference point, but variation is revealed. This issue affects this issue actually affects more than just number on the chart. It affect patient, hospital, and healthcare decision makers. High risk demographic groups are affected. Older adult and male patient are especially important when examining mortality pattern during and after the pandemic period. Second, acute care system are affected. Hospital faced increased complexity, especially with respiratory driven admission and related secondary diagnosis. Third, health decision makers are affected. Provincial health authority need clear evidence to standardize care, allocate resources, and reduce avoidable variation. So this topic is not only about data, it is about patient safety, hospital capacity, and healthcare planning. Now I will leave the floor to my colleague, Remy. He will continue with you.
Thank you, Hosam. Am I audible?
Yes, you are audible.
Thank you. And the next part of this presentation is the question why data matters. The hospital standardized mortality rate allows us to make fair risk adjustment comparisons across the various provinces. And this is so because the data is standardized across various disparities that includes age, sex, and comorbidities. So essentially, we're not just comparing hospitals, but we are comparing similar clinical conditions across the provinces. The value in this study itself is what it reveals about where the interventions are needed most. Think of the hospital standardized mortality rate as a signal detection tool that just guides us as to where to look. Now, how did we approach this study? We scoped this study through 5 key lenses to ensure a comprehensive system level view. First, we track the provincial trends over time. Then we examine the impact of COVID-19, which disrupted both access, care, and outcome across board and indeed globally. Okay. Next, we looked at who is most affected in terms of the age, the sex disparities, and the critical care conditions that includes specific comorbidities that we measured across the provinces. Fourth, we anchored everything to the HSMR benchmark of 100, which gives us a consistent reference point. Finally, we connected the outcomes to clinical drivers like pneumonia and sepsis, moving from the what to the why. So with these objectives in mind, the next question becomes, what data did we rely on to support this analysis? In the next slide, we itemized that the major source of our data is from the Canadian Institute for Health Information, which is the national standard for health system reporting. We also used multiple data sets to ensure depth and reliability. Included in the data are standardized fiscal year reports from 2020 to 2025 across all provinces except Quebec, where there were a bit of a gap between 2024 and 2025. And we also acknowledged this in the analysis and interpretation of the data. Now, with the data foundation established, let's walk through how we actually translated the raw data into meaningful insights. On the next slide, we'll see that our approach as a study team was structured and intentionally descriptive. We identified patterns and then we cleaned up our data sets, ensuring consistency across the provinces for the years under review. Next, we conducted a descriptive analysis that focused on the averages, the percentage changes, and deviation from the benchmark, which is the HSMR 100. We then applied trend analysis using time series and regression to understand the direction of the trend. In specific instances, there were some improvements, in others, there was a worsening, and in some cases, an equilibrium. But understanding these trends finally helped us layer on the provincial data, get results broken down into age and sex disparities. And these gives us a better system-wide view that allows us make meaningful deductions that can improve the health outcomes across the provinces. Now that we have an understanding of the methodology, let's look at what the data actually reveals across the provinces. My colleague Priyanka will take it from here. Thank you.
Thank you, Remy. These are our key findings. HSMR trends by province. As my colleague Hosam already told, what is HSMR? HSMR compares the observed number of hospital deaths with the expected number of deaths. You can see from this graph, the time series graph is this. This is a trend from the 2020 to 2025 of different provinces. And from this graph, you can see that the Newfoundland and Labradors remains the highest HSMR from throughout 2020 to 2025. And similarly, in Prince Edward and Manitoba has HSMR rate higher than 100. And whereas in Alberta and in Ontario and BC has HSMR rate continuously less than 100 in from 2020 to 2025. And in case of Ontario, and we will show that there is a progression in HSMR rate. When we see this graph on a map, we will able to present our finding in a systematic way. We have plotted the average of HSMR on map, and you can see that from this graph that the in northern region Nunavut and has lowest HSMR rate from 2020 to 2025 due to the small population or data instability. When comes to the western provinces, we able to see that BC, Alberta, Saskatchewan have HSMR rate below 100, and this show the stronger performance overall and continued focus on sustaining gains. And when we come to the Atlantic provinces, there is a highest HSMR in Prince Edward and Newfoundland region, a higher mortality rate, and this shows the system capacity challenges. And when it comes to the central provinces, Ontario and Quebec, we see the mixed results, mixed performance across the provinces, and opportunity to improve system efficiency. Overall, we can say that there is a fluctuation in 2021 to 2023 due to the COVID-19 system pressure. And overall, we see that HSMR trend is improving and persistent regional disparities remain a key concern for us. When we come to HSMR by age and sex differentiation, we able to clearly see that the male and older groups are relatively higher HSMR rate than compared to the females, and we have to target our strategy according to these data results. This will explain my friend Hosam.
We collected data about the top 5 diseases causing death in Canada. So we found sepsis, pneumonia, respiratory failure, acute myocardial infarction, and heart failure. And as you can see here in this paragraph chart, the red one showing different provinces, which is much higher than the national one. For sepsis, you can see it is 158, comparing with the national one, 125. Pneumonia, you can see it is 146, comparing with national one, 118. And this is proof our theory that it is really, there is a kind of unfair, and we should work on this. This suggests that mortality reduction strategy should focus strongly on condition-specific clinical bundles, especially for sepsis and pneumonia. I will leave the floor now to my friend Shelja. Please go ahead.
Okay. Thank you, team, for building on these insights. But the key question is here, what actions can we take to reduce hospital mortality and improve consistency across provinces? So our recommendations are focus on practical actions. So first one is like prioritize high burden areas. So first we recommend focusing on provinces and hospitals with the highest HMRs. Targeted quality improvement initiatives, especially for sepsis and pneumonia, can address the biggest drivers of mortality. So the goal is to begin implementation as soon as possible. Moving forward, scale proven protocols. Second one is like we scale what already works. Standardizing evidence-based clinical pathways across Canada will reduce variation in care and improve outcomes. And third one, strengthen our data and monitoring. So the data better leads to better decisions. Improving coding accuracy, introducing a real-time HSMR dashboard that introducing a real-time dashboard will allow faster response to emerging risk. The fourth one is we encourage a collaborative learning. So national learning network where hospitals can share best practices, learn from high performing regions. So last one is like building leadership and capacity. So finally, like long-term success depend on like how strong our relationship are, and coordinated governance policies and continuous staff training in quality improvement and patient safety. So I think together these actions create a clear and achievable roadmap for reducing avoidable deaths. Let's now look at the key conclusions for our study. So, in conclusion, our study shows that differences in hospital mortality across provinces are not random. They reflect system level gaps. So, we also see that older adult men and patients with conditions like sepsis, pneumonia are at the highest risk and should be the focus on targeted interventions. So, by standardizing care and strengthening data systems, we can significantly reduce avoidable deaths and improve quality in healthcare outcomes. However, achieving this will require strong policy support, and a leadership commitment is really important here, and sustained investment. Combined all these things, we can achieve our goal over there. Ultimately, improving hospital mortality is not just about better outcomes. It's about ensuring equitable, high quality care for every Canadian people. Thank you. We appreciate the opportunity to share our findings, and thank you everyone for your time and attention.
Thank you for the presentation from our data analytics stream, group 4. Now we have with us here today Arlenis and Savin Raj, and they will be speaking next.
Good morning, everyone. My name is Arlenis Rivera. I'm an international medical graduate, and I will give the time to my partner presentation to present.
My name is Savin Raj Sunkari. I'm an international pharmacy graduate.
And today we're gonna present our project. Our capstone project titled "Sex-Based Differences, Perceived Life Stress, Regular Healthcare Provider Attachment Among Adults in Canada in the period 2019 and 2020." Our project examines two important indicators. And our goal was to see if there was any kind of differences between females and males in these two indicators. And with these differences, we can find or help the healthcare planning in the future. What is the problem? Right now, the young adults have dual challenges: stress burden and like uneven connection in their routine care. Every young adults in early life, they can experience some kind of school pressure, financial instability, and they can even family issues. So these factors can influence in the stress, mental health, and use of the healthcare. In addition, Canadian Institute for Health Information reports the highest unmet mental health in this age group, 18 to 34 years. That gives a strong use of these indicators for planning in the future. Why this matters? First of all, they can inform targeted healthcare planning. Second, identify potential care in stress gaps. And third, support early sex-sensitive interventions. That means if we found differences between females and males, then one uniform approach can be kind of miss some needs in this patient, in this kind of. So this is our research question. How did perceived life stress and regular healthcare provider attachment differ by sex among young adults in this period, 2019 to 2022? These questions is a descriptive and comparative. We are not trying to look for cause and effect. We want to use it as a future findings to help the healthcare planning or healthcare planning and implications. Our objective is to quantify sex-based differences in high perceived life stress and provider attachment among young adults. This is our indicators, and our key planning was to see any sex-based differences in stress and provider attachment among different healthcare planning in these young adults or age group. This is data source. We collect the data from Statistics Canada, Canadian Community Health Survey, annual estimates. And then we use the two indicators that I really provide was high perceived life stress and the regular healthcare provider attachment. Then our data set include Canada, excluding territories, was weight annual estimates. We use for ages like 18 to 34 years. Stratified by sex mean females and males, because that's the data that we have available. And the period was 2019 to 2022. We just want to check how was post-pandemic and pre-pandemic. Our data method the data source was Statistics Canada. After we clean the data and filter in Excel, after we proceed with the analysis is descriptive and comparative. Then we proceed to analyze and visualize the data in Power BI. And after we do comparations by sex and year.
This graph shows the trend in high perceived stress by sex. Here, across all 4 years, females consistently reported high stress than males. For females, stress was 25.7%, in the year 2019, and it was 25.4% in the year 2020, and it was 24.9% in the year 2021, and it was 27.2% in the year 2022. For males, the stress was 19.6% in 2019 and 21 in 2020 and 19% in 2021 and 20.4 in the year 2022. So the highest stress was observed among females. It was 27.2% in the year 2022, and the lowest was observed among males at 19% in the year 2021. So in that previous graph, the overall female to male gap remained clear. So the next slide. Thank you. So this graph shows the patterns in regular healthcare provider attachment by sex for the years 2019 to 2022. Here, across the 4 years, females consistently reported high healthcare provider attachment, and for females, regular healthcare provider attachment was 79.6 in the year 2019, and it was 84.2 for 2020 and 82% for the year 2021 and 84.1% in 2022. And for males, healthcare provider attachment was 70.5 in 2019 and 68 in 2020 and 69.5 in 2021 and 70.6 in 2022. So the highest healthcare provider attachment was observed among females at 84.2 in the year 2020, and the lowest healthcare provider attachment was found among males in the year 2020 at 68%. This suggests that young adult males may be less consistently connected to routine care, which may represent a continuity of care gap requiring further assessment. So this graph shows the combined combination of two indicators, which is perceived life stress versus healthcare provider attachment. The main pattern is that provider attachment remained consistently high for both males and females across all the 4 years. At the same time, the sex differences remained clear. Females had higher stress when compared to males, and also they had higher healthcare provider attachment. So this is important because greater provider attachment doesn't automatically mean less stress. And this pattern is especially important among females who had both higher provider attachment and as well as they had high stress. So taken together, the findings show two important patterns. Whereas females consistently showed higher stress burden, which was 27.2 in year 2022, which is post-pandemic, and the males consistently showed lowest connection to the healthcare provider. So the lowest stress was also observed among males in 2021 at 19%. The highest provider attachment was among females in 2020 at 84.2. And these findings suggest distinct patterns of need by sex. For females, the issue may not be the supply of the healthcare or attachment to the healthcare provider, as it didn't decrease the stress levels, even though they had more attachment to the healthcare provider. For males, the issue was they had lower connection to the healthcare provider, which may affect the continuity of care and opportunities for preventive or early intervention services. So based on our observations, we propose few recommendations. Like first, Ontario Health and Ontario Health teams should use sex stratified monitoring of adult stress burden and provide attachment, because the findings showed consistent sex-based differences that may be important for regional planning. Second, primary care planners and Ontario Health team should review the lower provider attachment observed among young adult males as a potential continuity of care which is required, and also there is further assessment should be done on this. And third, youth wellness hubs, Ontario and other integrated health service models should strengthen early mental health support for young adults. And primary care services should not assume that provider attachment alone is sufficient. Attachment strategies should be paired with mental health screenings, brief intervention, and referral pathways for young adults. Future analysis should include broader determinants such as income, socio-economic backgrounds, and ethnicity and geography. So there are certain limitations for this because we use descriptive analysis only, so no casual conclusions can be made. Second, the measures are self-reported, which there might be bias, under-reporting or over-reporting. And third, the estimates are cross-sectional and do not follow the same individuals over the time. Fourth, only few years of data were included. And fifth, the analysis excludes the territories like northern provinces. So the findings are not fully generalizable to all Canada. Finally, the project did not include broader determinants such as income, ethnicity, immigration status, or rurality. And I give it to my partner. Thank you.
And for the conclusion, in sex-based, in our study, sex-based differences in high perceived life stress and provider attachment were observed among young adults in Canada. Females shows higher stress, while male shows lower provider attachment, suggesting distinct patterns of needs by sex and targeted healthcare planning. And that's all for today. Thank you so much for your attention.
Okay. Do you have any questions for Arlenis and Savin Raj? I'll take one question if you have any questions for them. All right. Thank you very much. What we're going to be doing at this time is to invite ACHEV just to come and speak to us for about 2 minutes, and then we will go into the panel discussion. So for the panelists, I'm going to ask you, please kindly make your way to the front so that we can start preparing for that. Come, Cherie, please go ahead.
Good afternoon, everyone. Thank you so much for inviting us today. I'm just going to briefly talk about our program. So this is a federal government funded program. We are assisting internationally trained nurses, pharmacists, and lab technicians. If you are one of the 3 professionals, and if you have a permanent resident status or open work permit valid more than at least 1 year or more, or Canadian citizen, refugee claimant, you would be eligible for our program. Oh yes, we also have a language benchmark level 7 or higher, so you would be eligible for our program. We guide you through your accreditation process in Canada, in particular Ontario and Alberta, and we assist with your job search. So this is a 4-year program. We are midway through. We have 2 more years. If you are any of the 3 professionals, healthcare professionals, please get in touch with us. We do 2 weeks essential skills training together. So we talk to you about your resume, job search, interview skills. And then we also provide ongoing one-on-one job search and licensing coaching. We work with various employers in Ontario and Alberta, providing potential job opportunity for you. Thank you so much. That's all. All the training is virtual. So if you are living in Ontario or Alberta, feel free to get a flyer outside. There's a table. I'll leave some flyers there. Come to talk to me. Thank you so much.
Awesome. Thank you, Sherry from ACHEV. And again, I like to always highlight that they have the Foreign Credential Recognition Program, which offers that loan to IEHPs. So as long as you are an IEHP or a trained international professional, you have access to that support. All right. So for those persons who are having challenges, you may think, okay, I cannot afford to pay for my licensure exam. You don't have credit score here in Canada, so I cannot get a loan. Then go to ACHEV. That's an option for you. You can get up to $30,000 in loan to go through your licensure process. Thank you, ACHEV, for presenting there. Now, at this time, we're going to be having our panel discussion. And with this, we're going to be having some system level conversation, looking at the healthcare system itself and how to support the integration of our internationally educated healthcare professionals here in Canada. We have joining us online, Happiness Rosemary Eze. Happiness is an international medical graduate and was recently matched into CARMS with the University of British Columbia. We also have Seinde Onobakpo, and she is an international medical graduate, also recently matched in CARMS to the University of Calgary. With us here, we have Wasim Al-Sabah, and he is a assistant professor here at the University of Waterloo, a pharmacist, a researcher, and he's also an international pharmacy graduate. We have Nasrin Alistaf, all right? And Nasrin is a nurse. She's registered here. She's an assistant professor as well at the Athabasca University and a researcher as well. Another researcher, also a nurse, we have with us. And for her name, I hope I do not get this wrong, Eberechuku Akadimna. Sorry, she's a nurse. Let me say she's registered with the College of Nursing, Ontario. And she also has training in global health. She has a Master of Science in policy, in health policy and equity. And is also doing a PhD now with the McMaster University, looking at health systems and society. And pharmacy, again, or representative from the Canadian Pharmacist Association, Kelsey Scromeda. She's a director there. And of course, the focus here today are really the association supporting our different professions. So Pharmacist Association, Nursing Association, and we try our best to get the other professions if they will engage with us. We had public health earlier today. Unfortunately, she could not stay. Pegeen could not stay for the panel discussion, but some valuable insights shared there. Now, I'm Dwight Baker, and I'm an international pharmacy graduate, not practicing in Canada, all right? And that's by choice, all right? Now, we have seen the various struggles that our internationally educated healthcare professionals go through as they seek to engage in practice here in Canada. The challenges that they face as they go through the licensure process, be it that they, want to say, I'm gonna just focus on the licensure process, or I'm gonna go through an alternative healthcare pathway. Either path that they choose, there are quite a bit of challenges that they will face. So when they go the alternative path, there is the concern about Canadian experience. And now you have laws being passed where you say, okay, we will not ask for this, or you do not put this in a TOR. But what exactly is happening at that level when you start with the whole screening process? When you go to the interview, what is happening at those stages? All right. And for those persons who are going through the licensure exams, there is costs that they have to think about. There is the Canadian context that they also need to be familiar with. So when you look at most of those licensure exams, you have what you call an OSCE exams that some persons will have to go through. And as brilliant as you are as IEHPs, you might say, okay, this one is easy. This is what I have been doing in all my years of practice. But then when you realize you're here in Canada, the conversation becomes a little bit different. So same conversation, but the context is now different. And so here, if it is that you're not able to respond in that Canadian context, you might find it difficult to pass that exam. And it's also adding up to the cost. And so at this point in time, I would like to allow the panelists to give their opening remarks. And we'll start with our in-person panelists, and then we'll move to our online panelist members. Let's start with Dr. Wasim Al-Sabah. Please go ahead with your opening remarks.
Thank you so much, Dwight, and I really appreciate this invitation. And the two advices that I would give in my opening remarks are, A, do not undersell yourself. You have a lot of experiences that you came in with. You just have to adapt to the new environment. That's number one. And I think one of the earlier speakers talked about having the pride, at the same time, the humbleness. Having this combination, although it might look contradictory, how I have a pride and humbleness at the same time, it is pride knowing who you are, and humbleness by how you are going to get inside the job market. So that's number one, do not undersell yourself. And number two is knowing that you are going to go through the process. Probably you have to go through more than the other party is going to do. Say we have to go through the gap. It's not 50-50. You have to go probably 70 to 80% of that gap, and the other party will not meet you in the middle. Probably they'll meet you at the 20 or 30%. So that's my two pieces of advice that, depending on my personal experience and being an educator for the last 10, 11 years here in Canada.
Thank you.
Hi, thank you so much. And I'm really humbled to be here with everyone. Good afternoon. It's not evening yet. I would say, first a correction, I am a researcher and professor at Mohawk College and teach the undergraduate program, McMaster Mohawk Collaborative Program at PSCN program. So just a little correction there. And a sessional instructor as well at Athabasca University. I would second say what Dr. Sabah just shared, and I would say my best advice I can give to any IEN joining the workforce in Canada, draw your own pathway. Don't let anyone do it for you. So if you know what you're good at, do it and have that kind of faith on yourself, because nobody knows what you can do except for yourself. And don't let anyone draw it for you. If somebody says go and work in an Uber drive, and this is something you want to do and have passion, fair enough, but don't do it because somebody drew that for you. So please follow your passion, draw your own pathway and follow that, and believe in yourself. Like, have confidence that you come in, like Dr. Sabah highlighted, their experience and expertise that are highly valuable to be shared within the Canadian healthcare system. So you're adding a valuable amount of everything that is needed to build our Canadian society and Canadian healthcare. So please have that kind of confidence and trust. The last thing I would say, get your information from the formal sources. It's great to have informal support, But trust me, if we all, and I'm sure that researchers, qualitative researchers will agree somewhat with what I'm going to say now. But if somebody says to you that this is my experience and I've read it this way, they might transfer it in their own perspectives. Always go back to the formal site. In Ireland, we used to say, get information from the horse's mouth. So please do. And reach out to somebody who's formally giving you information, because this is the best you could do to reach out your goals. Thank you.
Thank you so much to White and the members of Pegasus Institute for the invite. Welcome to all the attendees, both here and virtually. It's really lovely to be here and seeing all of your warm faces. I want to echo what Dr. Nasreen and what Dr. Wasim have said. Earlier during the profession-specific session, I shared a lesson that I learned from a webinar that I attended about the Pandora box, where the professor, Dr. Nadine Watson, talked about how it's a Greek mythology, how Pandora, out of curiosity, opened this box and let out all kinds of sorrows and miseries on the world. And she likened it to the state of nursing here in Canada, where there is just so much burnout, trouble integrating people. But it was also from Dr. Nadine that I learned, that I heard the full story, how Pandora Pandora, in an effort to control the mess, closed the jar and hope was trapped in the jar. There are so many ways to interpret the story, but for me, I'm choosing to understand hope in the jar as a form of sustaining power. And if we are to sort of translate or extrapolate this lesson to the reason why we are here, what I'm going to say is that the fight to integrate internationally educated healthcare professionals and the fight to sustain the Canadian healthcare workforce in general cannot be done in isolation. It is a very brutal fight to fight alone. Please get in touch with your associations, with your respective organizations. There is where we can harvest the hopes that membership offer. Thank you, everyone.
Thanks so much. So I think, I just kind of want to echo what our last speaker said. It really is about community. Especially, I'm looking at this from a lens of IPGs, the pharmacist licensure pathways. And I know that IPGs are certainly, things are improving. There are associations out there now providing integration supports from the beginning, but this is quite new. And, and access isn't universal. There's still a lot of folks out there just doing it alone. And being able to access more of these supports, having it funded, having them scaled up, but just, it's essential to find that community. And while I absolutely agree that the formal resources for information are essential, there is so much great information out there that formally is not being shared either. Just the on the ground, what is it like in that province, and so learning from both sources is so essential, but just finding that community very early on, because you do not have to struggle alone. So that's the most important thing. Thanks.
Thank you. All right, so let's go to Dr. Happiness Ize.
Thank you so much for the opportunity. So in addition to what all the previous panelists have said, so you just have to plan according to yourself. Like, it has to be specific to your scenario, to your situation, because some people do come over with families, some people come alone, some people have the financial capability to go forward with the examinations or the steps. So you just have to look, reflect, find out what works for you, and just apply the steps strategically. So that's just my recommendation. Thank you.
And Dr. Sisi Bakpo, please give us your first name.
Yes, so thanks for having me, and hello, everybody. So for me, I would say that in addition to what every other panelist has said this morning, is know your strengths and where you have opportunity to improve. There are lots of transferable skills, but understanding what your strengths are and leveraging those strengths, being able to speak about your strengths and your abilities in a way that those hearing you from a Canadian perspective can understand what you're saying. would be critical in selling yourself. So know your story and what you want to communicate in that story in a way that those that are hearing you can relate to that story. And then, being true to yourself in areas that you need to improve, understanding that the landscape is a little different from where where you've practiced, what you're used to, having that open mind to learn from others would really help you to integrate faster into the system, whether that is in an alternate career or even into the healthcare profession. It's critical to know where the opportunities for you to improve, leverage the resources that are around you to learn and grow. And we all have resilience and grit. We've made changes, just the migration, the ability to move to another country, settle in, that shows, resilience on your side. So don't give up. You're going to meet rejection along the way, but don't give up, because once you give up, then you never know what could be. So keep going. It can be hard sometimes, but keep going. And when you do not give up, you will get the results that you're looking for.
Thank you. My first question to the panel, and for this one, I'm going to just go by profession. So we have 3 professions here: nursing, medicine, and pharmacy. And I will just take one response from each of our panelists as it pertains to low cost. And we're looking at this in terms of efforts and successes, entry points into the workforce that you would consider for internationally trained professionals in your field. Let's start with Dr. Wasim.
So the first thing is the Canadian experience conundrum. I bet everyone who came to this country will speak for hours about this conundrum. You have to have Canadian experience to start your first job, and you cannot start your first job without a Canadian experience. How to solve this problem? Well, my advice is to find as close as possible to the sought profession and then move the ladder. That's my advice here. In pharmacy, for example, the pharmacy technician doesn't work, assistant doesn't work, the front shop, whatever that is, the closer the better, and then you move your way up. So that's my advice. The first step in the room, it is not impossible, it is difficult, it's the first hoop, you have to jump ahead.
Thank you, Dr. Alsaba.
I would say definitely get as close as you can for nurses. Like, I understand that some people say PSWs, and with all due respect, I'd say there are other pathways, and one of them is research and research assistants or administrative at medical offices. At least we get people to learn the system and how it works. I understand a lot of people were talking about the Canadian culture and how to provide care, but that's a great opportunity for us to understand the politics behind everything, and then do that at the same time seeking registration. Don't leave this at the last minute. So while seeking registration, maybe that can be supportive for your understanding to the context altogether.
Okay, I'd like to add a follow-up question to that one. Any geographic considerations that you think the IHP should be aware of as it pertains to those entry points?
Like geographic consideration? What does that mean?
Do we all stay in Toronto? Do we all stay in Waterloo? Do we go to...
Thank you, Do It. I think the majority of internationally, and I'll speak for nurses, I'll leave my other fellow colleagues to speak for their profession, but I know for a fact that nurses like to stay in big cities because this is where their support system is. I don't encourage or discourage, but I would say please find opportunities everywhere. Don't stick to the big city because sometimes it's competitive. We can't ignore that, and we can't deny it. It's competitive. Competition is actually increasing now with the newly graduate Canadian trained nurses. So when you're looking for jobs, they will prefer a Canadian trained nurse because they already trained them within their system. So I'd say just increase and broaden your horizon, even up north for a couple of years until you get the experience and the entry point, and then you can apply elsewhere. But that I'd say just refrain from big cities because that's where you don't get jobs.
Thank you, Doc. Just one moment there. All right. So
Pass it off. Okay.
we have quite a bit there. All right. Let me see here from medicine how that compares to what we're hearing for pharmacy and for nursing. So I'll take from Dr. Sisi, or let's go here in terms of an entry point. What would you consider to be most appropriate?
Well, to answer that question, I would say that the entry point would, highly depend on the skills and experience that the person is bringing. And so that would vary, depending. Some people have a master's along with their medical degree. Some people have worked extensively, for example, in public health. So it would look a little different for everybody. And to, what I said earlier is to understand where your strengths are. So if you worked in, administrative roles together with your health, like as a physician, right? Then your entry point will look very different from someone who was just pure clinical before coming to Canada, or who even has less clinical experience. So it will balance out based on your skills. Having said that, I agree with what the other panelists have said. The closer you are to what you want to achieve, the better. So, for example, if you wanted to get into public health residency, if you're looking for roles in public health, then that would add to your application, because you think about it as short term, long term. What am I doing in the short term that gives me, leverage for my long term goals, right? But if you're purely clinical, you can look for roles that keep you in the clinical space, right? Like clinical assistant roles, associate physician roles, that can help you in the long term. So I would say that there's no clear answer there. It all depends on your skills and expertise. Yeah, I'll pause there.
Thank you very much. And that leads to the next question. I am very happy for that response. What are some of the most effective ways? And I'll go to you, please. So what are some of those effective ways to gain clinical experience if it is that this entry point is not necessarily conducive to the IHPs entering the system, possibly in a paid role?
Say perhaps volunteering. I know that there are a lot of academic universities that are always looking for volunteers. I also want to mention something that I said during the profession-specific session, that the CNA runs a community forum where researchers are constantly looking for participants as well as people to join their research. So that will be a good opportunity. So volunteer like look for clinical roles like Dr. Nasrin mentioned, but also volunteer your time if you're not able to find a paid clinical role. I just want to quickly add one point based on the last question. Yes, it is important for internationally educated health professionals to put geographic locations in mind, but this is where we sort of bring in that systems thinking, and this is why we put the onus on government to collect proper census and data workforce so that we know where the needs are and we can better integrate them into the system.
So to look at that in terms of the integration steps itself or the process, in terms of geography, I want you, well, each of you can mention probably the location where you are seeing these working out, the different roles or pathways that persons can consider if it is that they want to remain connected to the profession while they, or even, for example, get an introduction to the profession while they're going through or starting the licensure process. What are some of those roles that you would suggest persons target?
For pharmacy, I mean, Dr. Wasim, already mentioned, unfortunately for pharmacy, getting into the pathway really starts at community pharmacy. And unfortunately, for that reason, IPGs tend to stay in community pharmacy even after licensure. It's an unfortunate thing that Dr. Wasim is researching right now. Very interesting studies on that. But really, that is generally the first place that you will get entry into the profession. Otherwise, yes, as was mentioned, research, staying connected in that sense. But, really moving into the profession, observing in pharmacy through a pharmacy assistant role, that's all you can do. As an unlicensed pharmacist, if you are not an intern, just observe. Try to work, observe, and that's how you're going to, continue on the pathway, complete the exams until you land into the intern position. But, I might ask Dr. Wasim to, sorry, I keep calling you by your first name.
It's okay. Thank you so much. So, in fact, this hierarchical structure that we found in pharmacy profession actually mirrors everything from medicine to nursing to all kind of health professions. It's a fact of the matter that IPGs or IMGs or INGs tend to go to a lower clinically challenging positions. I know this is not the most politically correct statement to be made, but that's what the data have shown. This is a reality. Now, you can always whine about the prejudice and racism, and this is not the only reason. This is probably part of it, but it is also systematic, structural barriers that prevent people from entering there. You can talk about managerial positions, you can talk about more advanced residencies and so on. So how to break those barriers? Now, the question is why people are not entering in those positions. The answer is, A, they are not aware. And we have shown that in our survey. About 2/3 of IPGs are not aware of the existence of the residency program to start with. B, they don't know the internal or the insider culture that will make you get that position. This is how to learn the language they speak. It's not the vocabulary, it is the culture. And number 3 is getting the internship, the observership in medicine, or probably in nursing. Those are the things. And I think associations are trying to help in this regard. In academia, for us, we are trying also. Not easy, but this is part of it. So just to summarize, it is a matter of awareness of the pathways for those more challenging positions, and it is the breaking the barriers through understanding the internal structure, the internal culture, and then try to again climb the ladder. I keep using this word. So.
Well, it's a very good one to keep using. Climbing the ladder. Yes, it's indeed a very motivating one, I'd say. And it's a very positive statement as well. So we welcome the repetition. Now, Dr. Happiness Eze. Now, for IMGs aiming to secure residency, so Dr. Wasim keep mentioning, he just mentioned those residency positions that are available in pharmacy. But what about medicine? For those who are aiming to secure those positions in medicine, what are those practical strategies that made the biggest difference in your success? And what would you do differently if you were given a chance to start over?
Thank you so much for the question. So regarding the residency pathway for the medical graduates, I think the first thing IMGs need to do is you need to research each of the provinces, because different provinces have different criteria and eligibility that needs to be met before you could apply. And this also applies to different specialization, like family medicine or other specialty programs. So you need to research these rules and see like what you have, what strengths you have, what areas needs to be improved on, and then you need to plan strategically for that. Secondly, I believe when it comes to writing the MCC exams, while during the preparation, you need to aim for really high scores, because this helps in improving your chances or your improving your portfolio for application. So it's very important. Then following that is the CV preparation, the personal statement. You really need to like self-reflect, look at that, what made you passionate about medicine, and you have to reflect all of this through your CV and through your personal statement, because these are the things that the committee will look at, and they'll be like, oh, I would like to interview this client, this person, and get to know more about this person. So, following that will be the interview preparation. We really need to prepare well. You need to be well versed with the communication techniques, interview behaviors, and you need to avoid those things that will be termed as red flags during interview. And the only way you can do this is through preparation, practice, if possible. So I applied 3 times to CAMS, and it was in my third attempt that I matched. So I think if I'm going to go at the process again, the thing I would like to do actually would be maybe like changing my strategy during my first application and then preparing very well for my interview, because I feel that's where I had issues in my first application. So that's just basically the residency pathways. Thank you.
Thank you very much, Dr. Ise. So now we have, again, lived experience and some practical insights there in terms of what exactly you can do in terms of strategies when we're looking at integrating into the various pathways. Now, following up on that, Dr. Onobrakpo, now, if it is that you don't match into CARMS, or you applied to PRA, for example, and did not get in, what could be a strategic next step if it is that you want to continue in healthcare?
Yeah, I think like Dr. Eze said, the strategic next step is to self-reflect, think about, go through that process again, think about what worked, what's in your story, what can you improve? Are there things that potentially you could do in the 1 year to the next CAMS that could help improve your profile or your story or your application? So things like recency, if you have the opportunity to, go back and make, and have recency, is that something that, you and your family, you can do, you and your family can accommodate? Is it that you need to do some more research, right? Like, have published articles. Is that something you can do? One of the panelists mentioned volunteering, getting yourself into spaces where you start to build, your soft skills, right? Collaboration, communication, and you can do those through volunteering. So thinking about organizations where you could build those skills, right? So it's back to just reflecting what you had put in on your application, looking through what the program was looking for in an ideal candidate, and thinking to yourself, where else can I make improvements? And then you go again. The second thing you need to do would be to look for resources around you, right? There are so many organizations, right, that support IMGs. So look for those resources, connect with people, connect with those that, matched, or connect with those that were successful with their PRA, and find out, what did they do that helped them to be successful? And then, see where you can adapt yourself, right? See where there are opportunities for you to leverage. And the third thing is be kind to yourself, give yourself grace. Dr. Eze mentioned 3 times. I also went through CAMS 3 times. So give grace to yourself. If this is something you want to do, then you go for it, right? And tell yourself it's okay. It's a competitive process. There are limited slots. The fact that you don't get picked the first time doesn't mean you will never get picked. But if you give up, you would never know. So, you go for it again. But this time you go for it with, a new strategy that, you can do this. And then the fourth is, whatever self-care you need to do, you do it. So if you need to take a break, take a vacation, relax, you do it. But then you come back to the table ready and prepared, because, it's a full process, right? It takes from you. So, if you need those, mental breaks, please take those mental breaks as needed.
Thank you very much. All right. So quite a bit of mouthful there in terms of the response, and I love the reflection piece. Now, Kelsey, I would like to pick your brains there. Now we look at Canadian experience, and we've heard it coming up so many times. It's been mentioned a lot by our IEHPs, and like Wasim says, it may be discrimination, but that is just a piece of it. Now, how important is networking versus those credentials that you will find our IEHPs have in entering the system in Canada?
I think networking is obviously something that that IPGs, that IEHPs should start doing from the get-go before you come to Canada. You know, questions, you know, you don't have to be selling yourself necessarily, but just building those networks, building that community, learning from others, and that is really how people are going to help you. You know, we've heard a lot from, you know, our participants, you know, going on Netflix, excuse me, going on LinkedIn and asking for jobs. No, that's not going to work. You know, what you need to do is sell your value, build those relationships, and then those people will remember you. Asking for favors to begin with is not going to help. But that's not to say that it's everything. You know, if you don't have any experience, there are so many other things that you can do as well, especially to get into pharmacy, you know, just, and networking is part of that. It's understanding the landscape, understanding Canadian pharmacy practice and all of that, and be willing to, you know, being able to share that with your employers. But of course, you know, building those networks, joining your associations, joining the LinkedIn groups, you know, making as many contacts with other IPGs, with other IEHPs, as well as those who, you know, I say that meaning unlicensed IEHPs, as well as those who are licensed, because, you know, being able to learn from each other as you're going through the licensing and credential recognition process is so essential too.
Thank you very much for that response. And I like to always talk about hidden job market when you talk about networking as well. That is where you will find a lot of those opportunities that will come through. So just like Kelsey said, you're not asking them for a job, but a lot of the times you will find those opportunities will come through some of those connections if you use them wisely. Now to Peace, thank you very much. We're based on your association and from your vantage point with the Canadian Nurses Association, where do you find most of our internationally educated nurses losing traction or losing momentum as they go through the process?
I don't know if I'm qualified to answer this question properly, so I'm going to ask Dr. Nasreen, simply because at CNA, what we do, we are not a licensure organization where we are more so a policy and advocacy group, and we just lobby federal government at the national level. Of course, we sit on many boards and we communicate with, you know, colleges to understand the needs and what it is that we can press forward. But I don't know that I have the insight to speak directly to where international educated health professionals are losing steam. So I'll pass it to Dr.
Okay. All right. Dr. Nasreen, maybe I'd say look at those barriers or where you find most persons get stuck in the system.
I think it's really important. Now, I pick up on Dr. Wissam's point on awareness. I think this is where they exactly get stuck. They're not aware of different resources. And this afternoon as well, I'll be talking about different other issues in next session. So you'll have to put up with me for about 10 minutes more. But I think really understanding where you can find those types of support. When you hear it from, like you hear somebody's experience is really not working well, or they're always focusing on that weakness, and they might follow their footsteps, and they're not necessarily applied. Like I get the gist that everybody is agreeing probably that it's individualized. Your story is yours and not mine. So I could be navigating certain processes different way. The requirements are still the same, but if I not fail, but if I don't manage to reach certain goals, that doesn't mean necessarily that you will too. And if something doesn't apply for me, it mightn't necessarily apply for you either. So it's really understanding where your position is and not give up on what you're trying to achieve, per se. If something, it's okay to fall on the ground, and that's fine, absolutely. And I know I say this because I've tried a couple of times, but the most important thing that you learn as a mature learner adult, and to show either the employer, the regulator, whoever you're trying to prove yourself and your qualification and expertise for, to show that you're able to pick up yourself and move forward. And I will not speak for resilience. Resilience is something that I'm sure that everybody will agree. I've seen it with IENs along the last, I'd say about 8 years now working with IENs. Resilience is great. Like, you know, you couldn't even ask them to do more than that. So resilience is one thing that will pick them up, but don't just look at the negatives. Like, always try and find where positives within the negatives and build upon these factors to actually achieve your goals. I'd say this is probably, I hope I answered it. I was trying to reflect from my own experience as well, but definitely have the strength to pick up yourself and just move forward to achieve your goals.
Thank you so much, Dr. Nasrin. So there we're looking at, I'd say, burnout. A lot of persons may find that to be the reality. And so I'll go back to now the statement from Dr. Wasim, where he says, climb the ladder, right? So you say when you fall, don't just stay there, you get up and you move forward. And like Dr. Wasim says, climb the ladder, all right? Thank you for those insights there. Now, at this time, I'll pause for 2 minutes and I'll allow you to gather your thoughts. And this is now for the participants. Gather your thoughts if you have questions. I will be taking specific questions. You can pose your questions to the different panelists for a response. 2 minutes.
Thank you all for a great discussion. Enjoyed it a lot. Being new to this environment, and I just learned about the conference and everything. I have so many thoughts. Pleased to see the help people are getting, the necessary help. As a professor, I teach a research methods course, and I'm keenly aware of the big tug of war between quantitative and qualitative evidence. And I'm so pleased to see that the judgment and the evaluation of people, it does work being composed of quantitative, namely test marks and so on, but also qualitative interviews, evidence about experience, evidence about reference and all that. That is great. But I cannot help not notice how some of the participants here, they did tell stories about having to interview 3 times, maybe even more. What does that say about that process of the interview where a person goes for an interview and the panel or the judges fail to see the substance, and the person has to go again and maybe take some behavioral something to appear different? And that is the question that kind of bothers me. And I'd love to know what you think about it.
It's an interesting question, very, very good one. I think the limitation is that, you know, the slots are limited. So because the slots are limited, the panelists have this huge tax, right? When you go for the interviews. And that's why I said it's not a reflection of your skills or your experiences or even how good you were at the interviews, because at the end of the day, they just have to make a decision for one person out of all the IMGs that apply to that slot. There's only one person that can get in, right? So, so it's not about changing your behavior in that sense, but when you sit, you reflect, you ask yourself, what could I have done differently? And so maybe you show up a little different to the next one. And I see Dr. Ese is smiling too, so I'll let her speak. But I think it's also just the limitation within the system barrier, right? The number of slots that are available. There are so many qualified IMGs, but unfortunately, getting into residency training is limited, right? I think for me, the bottleneck is in second and even post-match where CMG slots are not filled. So the Canadian medical graduates have a dedicated, slots. And when those slots are not filled, it baffles me that the system still says it can be offered to IMGs who are ready to take on those positions. And so they'll rather have that empty than have IMGs fill it and provide those services to Canadians. So for me, that's what baffles me. That I guess it's in first iteration if you have dedicated slots for your trainees. But in second and even post-match, when your trainees are not taking on that slots, you decide to leave it empty, and that's what they've done for many years. I think that's the one that baffles me. But I'll pause there. Dr. Eze, do you have anything to add?
In addition to what Dr. Onobrakwa said, when it comes to interview, yes, we have limited rules. There's the committee competition for so many people applying to a single role, and so there's obviously going to be competition in that aspect. But aside from that, we're all coming from different diverse cultures, and we all have different communication skills and techniques. And sometimes if you do not try to unlearn and relearn some of the Canadian ways of communicating, this could equally affect your interview performance. So I think that also is a factor in addition to the competition ongoing too. Thank you.
Thank you very much.
I was going to quickly say that I love how Dr. Onobra, or hopefully I'm pronouncing your name correctly, I love how she shifted the focus from individual to systemic, because truly this issue is a systemic issue. When seats that could be offered to internationally educated health professionals are rather kept empty, we must be asking questions. And I think this is where EDI policies become very, very important. The awareness of multiple systems of interlocking oppression, because you look at this also, and again, to be frank, the reason why we are here is because of this underlying mindset that the West is best and that people who have trained elsewhere must adapt to us, when evidence is showing us that internationally educated health professionals are more qualified than people trained here. They go through more rigorous training in their home countries than people trained here. That is what the evidence, I'm not making it up. Research has shown us this. So when this issue is occurring, we cannot simply blame it on perhaps you're not interviewing well, perhaps you need to look a certain way, perhaps smile a little bit more. No, the issue is systemic. And that is why associations like ours are doing the work of making sure of championing it. Equity, diversity, and inclusion, making sure that these policies are not just policies, recommendations, but are actually being implemented, and holding both federal and provincial governments responsible to do the work necessary to make sure that that our workforce is sustained and that we have a healthier Canada. So the issue, again, to recap, the issue is systemic, it's not individual. You cannot smile or dress your way out of a system that does not value you, does not see you as one of them, and prefers themselves. Thank you.
Thank you so much. All right, and quite a very high note for us to conclude on with Nurse Peace putting on her advocacy cap for the CNA. Okay, thank you so much. We really appreciate that. We really appreciate those being said. Now, at this time, I'm going to be going again in the same order. For your closing remarks, one takeaway that you would like our IEHPs to leave with, or something to implement in the next coming days?
So in social sciences, they have a nice term, I really like it, which is called social capital. In order to be advancing over the ladder, you have to have the social capital. Now, we immigrants tend to congregate with people who look like us in the beginning. That's understandable when I'm new here. But then I have to open my mind for more people with diverse background. And the more that you love to your money to grow in the bank account, your contacts, and the more people that you know from different backgrounds, from different aspects, that will increase your social capital. Then you can get more and more up in the ladder. Now, the relationship should be what we call mutual benefit. I should not be the one that is prying on others or being just a parasite on others, just give me without mutual benefit, or the other way around. I should not allow people to be only prying on me. Basically, it has to be a mutual benefit. I benefit you, or even being there for them. This will increase my social capital. Then I can go up and pick up on the cultural norms that I want to be part of it by having my social capital growing. So that's my concluding statement.
Thank you very much.
Thank you, Dr. Sabah. I think mine would be look at the full half of the cup. And if there is a quarter, look at that quarter. Don't try and find shortfalls in the system. We all know that there is always area for improvement within the system. Be the person to lead that improvement. So if you're standing there criticizing constantly, I was there, and the reason why I'm saying this, it does not work. So always look at the full side of the cup. There is small, look at that small, and just believe in yourself. You could be the changing agent within that healthcare system.
I started this session with a story about hope, and I also want to end on that note. Again, there is light at the end of the tunnel. This work is incredibly, incredibly hard. And like Dr. Nasrin has mentioned, this is not a fight that you can do alone. At CNA, we are happy to, we want you to come join us, come help us shape and inform policy decision. We have a national conference coming up. If you can afford it, please do come network with people. Your networking is important. You are your own best advertisement. I'm telling you that. Your credentials are important, but also you need a strong network of people to help you get through this very tough system. Thank you.
From my side, I will say, we all know that the healthcare workforce is in a shortage situation. It's been in a crisis for a long time, but this is actually a very good time to be an internationally educated healthcare provider coming to Canada and becoming licensed. There have never been as many supports as there are now for you within the process, be it government-funded changes and pressure on the regulators to change their practices, to make things less one-size-fits-all, to funded programs like Pegasus, like our mentorship program at the Canadian Pharmacists Association. So definitely use these resources. I'm sure that there will be more to come, hopefully, but now is the time to really take advantage of them.
Thank you. Now let's go to Dr. Happiness Eze.
Hey, so in addition to what every other panelists have said, I will recommend each person here should create a personalized integration plan. And this plan should be divided maybe into short-term goals, long-term goals. And this should also include the different pathways you feel you might be eligible for. And you try to connect with people, just take actions. And with plan, the process is not going to be overwhelming. It will reduce the probability of burnout and mental fatigue, because once you have plan, you're able to take things one step at a time while at the same time being kind to yourself. So that's just my recommendation. Thank you.
Thank you. And Dr. Sisi?
Well, I think everybody has said great things. So I would just add, don't give up on yourself. You've got this. And you can do it. Thank you.
All right, so it's all been said. Thank you very much. The mutualism, Dr. Wasim, Dr. Nasrin, the leading, the improvement, right? Looking at the cup half full rather than looking at it half empty, and then peace, networking. Thank you very much. Embracing the healthcare system. So don't just say, okay, let me go to drive Uber or go to work in Tim Hortons because it may be easier to get there with my customer service skills or client patient skills. You understand? So you say, embrace the healthcare system. You can get in, and that's very good. Thank you for those. And the job science, Happiness just brought that up, right? So sit down and write out that structure. It is what is gonna hold you accountable. It's your accountability piece. So you check off, okay, I achieved this, okay, let me move to the next step. Very good. and then being true to yourself and being supportive of yourself. Okay, thank you, Dr. Sisi, for that one. So thank you to our panelists for the insightful, the practical discussion that we just went through. It's not just about a single pathway, and that's what I'm hearing from the discussion, from the different recommendations. Licensure is just one of those pathways, but not the only one, all right? And so to our IHPs that are still here online, workforce entry often happens parallel to the licensure process itself. So be open to doing both at the same time. Networking, positioning, and persistence. So we mentioned the resilience and of course the fact that sometimes we might feel a bit burnt out in the process, but you persevere, you will get there. Thank you all. And at this time, I'll take my leave from this podium and we'll now go back to our learning stream presentations. Oh, before we go, I would like to hear from Dr. Nasrin, who has been supporting IEHPs in her work. She recently got an award, and I would like to highlight that here this afternoon. Thank you. Please welcome Dr. Nasrin.
Hi, everyone. I'm always calling myself the person with no notes. So this time I forgot my glasses, my notes, and my comments and everything. So hopefully I will not make this really too long, but I would just like to first thank the organizers for this opportunity. I'm really humbled to be here. Just wanted to highlight, I was thinking, what is it I want to bring to this place that is different that you didn't hear? So I just wanted to reassure, first, as you all know, I am an internationally educated nurse. I couldn't be more international than I am because I was born in a country that isn't my home country. I trained my basic nursing degree in another country and then decided to do my first work in a third country and then moved all together to a second continent and then moved to North America. So if I map this out now, I started moving when I was 1 year old. So that took me about 25 years to be here and be registered and complete my training and PhD and postdoctorate. But the most important thing that I was talking about is resilience. And I think it's really important to highlight within our community as internationally educated healthcare professionals. I think it's something that you can't teach. It's something that builds in within your profession as you taking care of your patients. Advocacy is another thing. So I will not talk about things that you know already, but I will be highlighting the part of work I was involved in and currently completing is work to unpeel the systemic challenges that everybody has touched upon that is leading to the delays and the frustration, and people mightn't even know how to navigate system and just go into a comfort zone where they can work as Uber drivers, etc. And we'll do, with all due respect to everyone, I think we're trained to provide healthcare, and I think that we should really we deserve to be working within where we are trained. So part of the work that I am involved in is navigating the licensure process for internationally educated nurses across Canada. When we completed the work, this is a CIHR-funded project through Athabasca University. What we did, we looked through across Canada to every jurisdiction. I just wanted to say, in Canada, the 10 provinces, there are more than 22 jurisdictions for nursing, including LPNs, RPNs, RNs, etc. Nova Scotia, Ontario, and British Columbia are found to be the three provinces with one jurisdiction for nursing to regulate the full nursing body. And joining now as BEI and some others are trying to just amalgamate their jurisdictions together to become one jurisdiction, as evaluating in those provinces. The territories didn't allow IENs to apply directly through their regulator before they are already licensed in another nursing or Canadian nursing jurisdiction in Canada. So now UConn are opening their licensure to be directly applying through them. I understand their process slightly I'm not going to say more than probably, for a lack of better term, a weird process. But you apply to UConn through British Columbia, they do your credential and then send back again to UConn to say, can you become a licensed nurse within? Loads of reforms are found. So the survey that we completed was environmental scan. We looked through all Canadian provinces, through all jurisdictions, and we found the requirements for licensing are exactly the same across all 10 provinces, but the options available for nurses, for IENs to become licensed within these jurisdictions are differ. And they're different in terms of the time that you are safe professional practice. Some provinces say if you're from certain designated countries, so all of those expedited pathways. So we're still in that process of trying to figure out what works best and why we're saying certain reforms or regulations or policies implemented are better than others. So we are in that process. We are in the process of interviewing everybody within that pathway. So would it be a regulator, educator, employer, and IENs themselves to look at what are the impacts of licensure changes or reforms changes on their professional licensing and securing even employment. So we're expanding even our horizon to go beyond licensure. The last comment I just wanted to say that I'm just recently back from from Nova Scotia, and the 1 hour difference of time just did my head fog. But I can say, I think we seem to believe that we are now sorted for our licensure process, changing regulations and policies, and now we need to focus on employment. My comment on that is that we're not sorted yet. There is a lot need to be found, and there's a lot need to be navigated. So please join me to actually bring our voice up to front stakeholders, whether it be federal government. I was talking to Dr. Lee Chapman, who is extremely supportive of IVNs and trying their best to actually modify regulations to actually integrate the most we can. I understand those who are, especially who are familiar with the supervised practice internship program for IENs, are slightly frustrated because they are now trained and secured licensure but can't secure employment. All of these voices reached out there. So please make sure to bring your stories, your voice, your story matter. And I assure you, change will happen. I know it's slightly slow. I don't have a magic wand to change system, but all together we can do it. Me alone can't really make that change. So please join me to bring the voice up to any healthcare profession. Please collaborate, because that's the only way we can cause change. Thank you so much.
Thank you so much, Nasreen. And congratulations once again. I've been working with Nasreen on a few projects since 2023. And I know how dedicated she is. And she deserves every bit of the award. So round of applause to you again. Up next, we do have some of the learning stream presentations left. And I know in our agenda, this is the time to network and connect with each other. So we're going to slightly improvise because of the time constraints. We do have the presentation running, but if you feel like you want to connect with someone, feel free to take the space or outside or anywhere, and that's completely okay. But we also have a series of interesting presentations. So we can start that. So in the morning, you saw presentations from the data analysis learning stream, where they use the skills on data analysis. And from now on, we'll be seeing 3 presentations from the evidence-informed decision-making learning stream, where they use the skills and techniques from the NCC-MT modules to see how they can make evidence-informed decision-making in public health.
Hello, everyone. So coming to our presentation, most of us have experienced this, but I would like to say we ignore a small symptom and we think it's not a big deal. It's okay to go ahead with that until suddenly it becomes something much harder to control. Public healthcare works the same way. So small gaps don't stay small. They grow, they spread, and that's And that's exactly what's happening with measles in Canada today. And a disease we eliminated is now back. Good afternoon, everyone. My name is Harita, and today our team is presenting on gaps in protection, the role of local vaccination coverage in Canada's measles resurgence. And what we'll show is this: it's not the overall system failing, it's the small hidden gaps in protection that are driving outbreaks. So I would like to begin acknowledging that we are on the traditional territory of Neutral, Anishinaabe, and Haudenosaunee peoples. I'm so sorry for the pronunciation. We recognize their enduring presence, knowledge, contributions, and reflect on our shared responsibility in advancing respectful relationships and learning. Here is a quick overview of what we'll cover. We'll start with the background and public health context, then move into our research question, key evidence, followed by a critical insights, and finally discussing implications, recommendations, and conclusion. I'll be setting the context for how these vaccination gaps translate in real-world outbreak risk. So Priyanka can take it over.
What causes the measles resurgence in Canada? In 1998, Canada was declared elimination for the measles vaccination. But we can see that from this graph, from time to time, from 2001 and in 2012 to 19, there are some small outbreaks, but we never experienced that the elimination status is lost. In last last year, from 2024 to 2025, we have experienced like 5,000 cases has been declared measles cases in Canada. And I would say and most of the cases occurred in the unvaccinated or under-vaccinated area, and these viruses contaminated and retained for the more than 12 months of sustained transmission, which why we have lost the Canada elimination status, and it is the resurgence of Canada measles status. Next, and it indicates a reversal of decade of measles control progress. Next slide. Thank you, Harita. And we are focusing on Ontario's cases, and why we are focusing on Ontario's measles cases. Actually, in 5,000 cases, 24,000 cases were found only in Ontario. And this is the largest measles outbreaks in Ontario. And in this graph, in this Canada's map, you can see that the red pointed areas, red highlighted dots are showing that the high cases, high measles cases in Ontario. And these cases are due to unvaccinated, rural and urban remote areas and vaccine hesitancy cases. And when you see the blue dot, these are the cases where the you can't very low incidence because the people have taken vaccines, and there is a very less incidence of vaccines, very less incidence of measles cases, sorry. And from this we can say that MMR increased susceptibility in under vaccinated population and rapid spread in high contact community networks. Okay. Here we are presenting that how low immunization coverage is associated with the higher measles incidence in Ontario. We have plotted a graph between the measles incidence and measles immunization, MMR immunization coverage. MMR here stands for mumps, measles, rubella immunization coverage, and we have plotted the graph we have found out that there is an inverse relationship between the measles incidence and MMR immunization coverage. So it's better to immunize the people and immunize the children and to reduce the measles outbreak or measles disease. And you can say that, and we can infer that the health units with the coverage below 90% have higher measles incidence, whereas the health units which have 95% coverage continuously report low incidence. And when it comes, why this matter for the public health decision making? You can see that we are lost the elimination status, and because of all this is a system signal which signifies that we are declining population immunity, which indicates weakening herd immunity, which prevents us from the outbreaks and prevents from the pandemic as well. And when it comes to the patterns of risk, we have seen that the red dots which are showing the patterns of risk, and it is not evenly distributed. It's scattered in one place due to unvaccinated or vaccine hesitancy pockets. It's driven, so we conclude that it's driven by the localized immunity gaps. And when it comes to the understanding vaccinated gaps, we were trying to understand where is the MMR coverage below 95%, and how does the low immunization coverage relate to the measles cases. And we have to need to think like linking it between the vaccination gaps with the transmission. And our research question is, how are the vaccination in MMR vaccination coverage associated with the measles incidence in Ontario? So by this way, we are trying to find out, are the areas with the lower immunization coverage associated with the higher measles incidence? Secondly, do geographical cluster of low coverage align with the outbreak incidence? And thirdly, what patterns emerge across the public health units in Ontario? And then for this research question, we have tried to find out with our evidence research strategy, and we have searched on the PubMed and Web of Science and Scopus, and all that the search engine, and the data the search, and we try to find out the peer reviewed articles and systematic review article, and the focus areas was MMR coverage by outbreak and immunization coverage. And the population we are focusing on Canada, and particularly Ontario focused, and we try to find out the articles from the 10 to 15 years. And our key search terms was MMR vaccination coverage, MMR incidence in Ontario, vaccine hesitancies, and outbreak. And when come to the exclusion criteria for our research topic was non-measles MMR vaccines or non-measles studies and non-English publications and clinical studies only. We followed the 6S framework, and we started to find out the research article from the summaries, and we were able to find two articles, actually policies like Global Measles Elimination and Immunization Action Plan for Ontario. And when we come to the downwards for lower, more work on this, and we find one article on synthesis framework, like infect susceptibility in the fight against measles. And then we were not able to find anything on synopsis or single study, so we go to the primary studies, and we were able to find measles in Canada modeling studies, and measles in Ontario, and measles surveillance studies in Canada. And firstly, what is our procedure for finding the article is like we've started the databases, and then title and abstract screening, and then the full text review. Then we applied the critical appraisal. And in the critical appraisal, we have used the tools like CSP for the qualitative studies, and JBI for quantitative studies. And the quality scoring was, for the high quality study, we have given the score greater than 80%, moderate quality 16 to 90%, and low quality studies. And the inclusion criteria, we have only included moderate and high quality studies in our. And when it comes to the applicability test, we have used the PICO test. In PICO test, is PIP stand for population, and population we have considered here is Canada, and we are focusing on the Ontario side. And I for intervention, and intervention is in our study is the vaccination coverage. And when it comes to the O, and the outcome, measles incidence or outbreak risk. And the final inclusion requirement is methodological quality, high contextual applicability. And then the final included, we have included these 5-6 studies in our research. And when it comes to the key limitations, every research has a key limitations, and our study also have some limitation. Like number one is data quality and completeness. Underreporting and inconsistent surveillance across region may lead to underestimation. And the changing epidemiology, like every time we can say that after some many years the trend will change. So waning immunity and shift in the age distribution may not be fully captured in existing data. Modeling assumptions, we have also included a modeling study. Modeling study depends on the assumptions about behavior, immunity duration, and vaccine effectiveness. So that's our limitation. And generalization, finding from specific settings may not be fully applied to the other contexts. And then comes to the equity and access gap, unlimited data within the province disparity and marginalized population. These are our 5 key limitations for our studies. And when now we come to the key findings. The key finding will explain my friend Femi.
Thank you. Femi Ibrahim is my name. I'm an international trained physician. I'll be discussing the key findings in this study. We should note that the evidence showed that measles resurgence in Ontario is consistently linked to localized gaps in the MMR vaccination coverage, especially where under-immunized communities enable cluster transmission despite overall high provincial coverage. So these key findings will be discussed looking from the global challenges to measles elimination, to the surveillance in Canada, and then details of the Ontario measles outbreak that added to the loss of the measles elimination status in 2025. So there's been a global stall in the elimination of measles, despite the fact that all WHO regions are committed to the global elimination of measles. It's noted that the global coverage of the first vaccine stalled for a decade, and this dropped further during the COVID-19 pandemic. The Americas achieved elimination in 2016, but this was lost in 2019. Surprisingly, strong routine immunization coverage that is more than 95% is neither strictly necessary nor sufficient on its own to achieve elimination. In fact, 68% of verified eliminated countries did not reach the 95% routine coverage target, instead relied heavily on targeted vaccination campaigns. These delays create a vicious cycle, which you can see on your right, that increase inequities within and between countries. Measles cases are increasingly concentrated in low-income countries facing multiple crises, widening the global equity gap. It's also noted that in areas with suboptimal coverage, delay in immunization causes the average age of the infection to rise. So we have more outbreaks occurring in older children and adults. And this also has raised the risk of congenital rubella syndrome, where your MMR is used. And also in eliminated settings, the immunity is waning more quickly because infants born to vaccinated mother lose their protective maternal antibodies faster and at a lower level than infants born to naturally infected mothers. In the study done here, it was found out that infant measles immunity drops rapidly after birth, with seroprevalence decreasing from 70% in the first month to 0% by fourth month. Inadvertently, the predicted probability of susceptibility was about 25% in the first month of life, and this increases to over 90% by the 3 months of age. And you can see in the chart showing an inverse relationship between seroprevalence and the susceptibility of the infant to the measles infection. But some factors have been noted to be protective for the baby. Babies that are born to Canadian mothers are twice more protected from measles compared to infants of mothers born outside Canada. And then the feeding methods used. So exclusive breastfeeding protects the infant more than formula fed or mixed feeding. And infants are likely susceptible to measles for the first year of life, even before they receive their routine vaccination at 12 months. So a study done in 2018 to assess the cases of confirmed measles in Canada showed that 29 confirmed measles cases were seen in 5 provinces, with the highest number seen in Ontario. And of all these cases, the incidence rate was 0.8 cases per million, and the highest incidence was seen in infants that are younger than 1 year of age. Most of these infections were imported, and there were few secondary transmission within Canada. And the transmission was restricted to household or close contact, and there was no outbreak spread beyond the second generation. An important thing was that this infection occurred in under-vaccinated, with 20 out of the 29 cases they were not up to date for their measles vaccination, and there were few admission. Despite this transmission, which was localized, Canada still maintained its elimination status. So I will hand over to Camila.
Yes, thank you. My name is Camila. I'm an international medical graduate. Continuing with the evidence, I'm presenting a study on measles dynamic in Canada, especially as global case continue to surge using a stochastic SEIR model. Research exploring how vaccination coverage and public health response shape the impact of outbreaks following viral importation. The findings are clear. At 95% coverage, 99% of measles introductions do not result in an outbreak. However, the study identifies a critical threshold of 85%. Below this level, outbreak sites escalate dramatically, potentially resurging hundreds of cases in vulnerable communities. The research highlights that strong interventions such as rapid contact tracing and post-exposure prophylaxis are essential to keeping most outbreaks containing and under the 60 days in duration. Additionally, the team developed an interactive web application to the public health agencies project local risks and evaluate the intervention scenarios. In conclusion, while Canada is unlikely to lose its elimination status, this study warns that maintaining high coverage and fast public health action is our only real defense against sustaining transmission in under-vaccination pockets. Okay, this one is a epidemiological summary of measles in Ontario. The most critical finding is a major change in our public health status on November 10 in 2025. We can continue? Okay. November 10, 2025 can officially lose its measles elimination status due to sustained transmission of the virus over 12 months. This followed Ontario's largest outbreak in decades, with more than 2,000 cases between October 2024 and October 2025. Current surveillance data for the first quarter of 2026 show that the virus continues to circulate, with 16 confirmed cases. Our analysis revealed two concern trends. The first one, immunization gaps. 81% of the current cases occur in unimmunized individuals, highlight a significant vulnerability in a population coverage. And the second one is the demographic risk. Infant, children, and adolescents count for over 65% of the case, through the nearly 45 are adults, indicating a broad age-based risk. This is our last evidence. It's a report which analyzed the large measles outbreaks in Ontario, which I discussed previously. The study basis on engagement with 29 public health units identified the lack of comprehensive provincial immunization registry as the primary barrier to an effective response. Researchers found that the outbreak was driven by localized pockets of low immunity where vaccination rates fell well below the 95% herd immunity threshold. And to address this vulnerability, the Ontario Immunization Advisory Committee proposed a provincial call to action, and the three most urgent recommendations are: one, the immediate implementation of a digital immunization registry; two, the expanding small area surveillance to identify specific high-risk communities; and three, standardizing the enforcement of school immunization legislation across all regions. So in conclusion, modernizing our information system and closing these immunity gaps are the essential steps required for Canada to regain its elimination status, and proceed to the public from future outbreak. Thank you so much, and one of my colleagues will continue with the presentation.
So now going into the critical insights, looking across the evidence that Camilla and Fem has just shown, we see a clear and consistent pattern. Low vaccination coverage is associated with higher measles incidence. These findings are supported by strong plausibility, especially with what we know about herd immunity. However, it's important to interpret this carefully. So, most of the studies are observational and population based, which means they show strong associations but not direct causation. So, overall, we would classify this as a moderate quality evidence, but with consistent trends across multiple data sources. And importantly, it is a strong enough to inform public health action. It highlights both strengths and limitations of the evidence. On the strength side, we are working with large real world population data, and findings are consistent across regions with strong biological plausibility. At the same time, there are important limitations. These include risk of ecological fallacy, where group level findings may not apply at the individual level, as well as confounding factors like travel, socioeconomic status, and clustering. There are also issues with underreporting and incomplete vaccination records. So while we need to be cautious about overgeneralizing, the overall patterns remains clear and meaningful for decision making. To you, Melanie.
Good afternoon, everyone. I am Melanie Atienza, and I'm an international medical graduate. So, for the application to Ontario's public health context with to just apply our evidence gathered. Ontario's public health system, as we know, has a history of stability, even though it has some weaknesses. The 2024 to 2025 measles outbreak prompted discussion about opportunities for refinement. With nearly 2,400 confirmed cases, this outbreak contributed to Canada losing its measles elimination status. Notably, transmission was not evenly distributed. It was concentrated in communities where vaccination coverage fell below the 95% threshold required for measles herd immunity. These immunity gaps were further intensified by structural limitations within the system. Most importantly, Ontario lacks a comprehensive province-wide immunization registry, as emphasized by my groupmates. With centralized data, public health units have limited ability to conduct small area surveillance or efficiently manage cases and contacts during outbreaks. Certain populations are also disproportionately vulnerable. This includes temporary residents, such as migrant workers and, well, international students as well, individuals without primary care or more specifically OHIP coverage, and infants under 1 year of age. In infants, maternal antibody protection declines rapidly, as mentioned by Femi, from about 70% at birth to nearly zero, leaving them highly susceptible before routine vaccination at 12 months. Okay, next slide, please. Let's assess the acceptability assessment of our recommendations that I will show after this. So in terms of feasibility, our recommendations show a strong overall fit within Ontario's public health context. Politically and organizationally, they align well with the existing mandates and infrastructure already. However, there are some challenges, of course. Social acceptability is partial due to vaccine hesitancy and mistrust in certain communities. Resources-wise, while Ontario has strong foundations, there are still gaps that remain. particularly, as I mentioned, the lack of a centralized registry and the need for sustained funding for outreach to communities. Overall, implementation is feasible but requires targeted efforts to address these barriers. This is our recommendation slide. It's a little bit a lot, but just to summarize it, based on our evidence, the ones we gathered, we have 5 recommendations. First, Ontario needs a provincial immunization registry. You have heard that the whole presentation. Our studies found that the absence of one was the most significant reason why public health units couldn't identify vulnerable communities quickly enough. Second, public health units' enforcement of immunization records need to be standardized. The studies found that data collection practices vary widely across public health units, creating some blind spots. Third, an equity-driven, culturally tailored outreach is recommended. Ontario, as you know, is one of Canada's most diverse provinces, just second to BC. And is often considered the national leader in total visible minority population and newcomer attraction. Particularly in the GTA, we hold a high concentration of a diverse population. It is really necessary for an equity-driven, culturally tailored outreach to these communities. Fourth, PHUs need to be resourced for rapid response. Our modeling study showed that even at 80 to 85 coverage, a strong and fast intervention can still contain an outbreak to under 60 days, while a slow response cannot. And lastly, infants, because they're very vulnerable, under 12 months need explicit outbreak protocols. Our study found that maternal antibody protection drops to 0 and leaving most infants completely unprotected before their first MMR, the vaccine dose. In conclusion, the Ontario outbreak demonstrated that aggregate vaccination coverage alone is not enough to reflect true population immunity. When coverage falls below 95%, localized susceptibility gaps definitely can be seen. And outbreak size increases with population size, placing disproportionate strain on public health systems. It is also highlighted that immunization infrastructure is just as important as vaccination rates. The absence of the centralized registry and inconsistent policy enforcement are not minor gaps. They are systemic issues that limit effective outbreak response. Finally, sustaining measles elimination requires addressing structural determinants of under-vaccination, including access barriers and vaccine hesitancy in different communities. Regaining elimination status will require coordinated action across 3 key fronts, as you can see in our presentation. First, modernizing immunization tracking. Second, strengthening public health enforcement. And third, ensuring equitable vaccine access, especially for vulnerable population. The evidence is clear. What is needed is coordinated action, sustained investment, and strong community trust. Thank you so much for listening to our presentation. These are our references.
Please save your energy. I have something to say. So to conclude, measles resurgence in Canada is not simply about declining vaccination, but about where and why the gaps exist. Structural barriers, access issues, and trust all play a role in creating these pockets of vulnerability. If we need to regain elimination status, we need to move beyond overall averages and focus on targeted, equity-driven solutions. Because in public health, protection is not only as strong as the most vulnerable community. Thank you for your attention.
So they had their slides from PowerPoint, and when we transfer it to Google Slides, it has some misalignment. So next we have Ekata, Bushra, Adibola, and Franger presenting.
Hello, everyone. We will present our presentation about we studied about the depression and anxiety in the engineer student. In Waterloo University, we are Adibola, Ikata, Franger, and me, Bushra. Our presentation is comparative effectiveness of mental health interventions among engineering students at the University of Waterloo. My colleague Adibola, she will start this short presentation.
Good afternoon, everyone. So today we'll be assessing the comparative effectiveness of mental health interventions among engineering students at the University of Waterloo. Engineering students experience higher levels of anxiety and depression, yet we still don't know which intervention works best for them. So anxiety and depression are among the most common mental health challenges in university students. However, this burden is higher among engineering students due to heavy workloads, competition, and performance pressure. This impacts not just their well-being, but also the academic performance and attrition. Universities offer structured programs, including CBT, cognitive behavioral therapy, counseling services, and peer support, which are usually student-led initiatives, but their relative effectiveness remains unclear. So at the University of Waterloo, decision makers must allocate the limited mental health resources. So the question is not just what works, but what works best within the real world constraints. And we're looking at this vis-a-vis the effectiveness, accessibility, and acceptability, feasibility, scalability, and equity. Ultimately, decisions must balance impact with practicality. So we asked, among engineering students aged 18 to 30 at the University of Waterloo, how effective are structured campus mental health programs compared with peer support in reducing anxiety and depression? To answer this, we reviewed high-quality evidence, primarily systematic reviews and meta-analysis, and supported by public health data. This allowed us to combine clinical evidence with real-world insights. The evidence base was strongest for systematic reviews and meta-analysis, which focused on intervention effectiveness. Public health reports added policy and population-level context, but less evidence was available on context-specific implementation. One clear pattern emerged. Structured mental health programs outperform peer support in reducing anxiety and depression, but peer support plays an essential complementary role. For the structured programs, the group CBT had the strongest effects, followed by the digital CBT and mindfulness. Psychoeducation had smaller effects, but still meaningfully beneficial. Peer support had some limitation in that peer support alone does not significantly reduce symptoms, but it improves access to care, reduces isolation and stigma, and promotes engagement. Peer support, it acts like a bridging, a critical bridge into care, in that students are 2 times more likely to seek professional help after peer support. However, evidence specific to engineering students is weak, which is as a result of it mostly being descriptive and unable to determine what works best. So for the critical gaps, despite the strong global evidence, key gaps remain. There are no direct comparison between interventions. There were limited engineering specific research and few long-term studies. And most evidence is short-term, small scale, and not Canadian specific. So while this evidence is strong globally, it is not yet decision ready at the institutional level. Additionally, many studies have small sample sizes, and there was a self-selection bias. And like I mentioned, follow-up periods are short, limiting long-term insights. Definitions of peer support were also not consistent, and much of the evidence comes from outside Canada, which limits the generalizability. So together, this reduces the reliability and applicability of the evidence. So the key takeaway is this: structured programs have they drive clinical outcomes, while peer support improves access and engagement. But we lack strong context-specific evidence to guide decisions for engineering students. So I would now leave the floor for Bushra. Thank you.
Now we talk about evidence at a glance. Dimensions, there is general university interventions which are strong evidence, but there is gap less specific to engineering. Canadian post-secondary data, it's a growing in strength, and there is a gap in limitation of specific Waterloo University. There is peer support models, it's emerging in strength, and because of the gap of inconsistent definitions. Engineering student mental health, this is a recognized high need and strength because of the gap. There is gap under research as distinct, and there is long-term outcomes in strength is limited, and there is a major gap. Critical appraisal, the strengths in our study they are strong evidence for systematic reviews, clear support of CBT groups more than digital, consistent findings across studies. And there is limitations, few direct comparison structured vs peer support. Peer support evidence weak, limited engineering specific research, and lack of Canadian University of Waterloo specific data. Critical appraisal as well. Methodological concerns, it was in small sample sizes, and we addressed that in piloting 12-month study at University of Waterloo. There's short follow-up periods, and we addressed that in monitor outcomes over 24 months. Self-selection bias, we addressed that in targeting engineering cohorts. Inconsistent peer support definitions, we addressed that by position as tier 1 complement only. Applications of practice policy, what this mean in practice. Instead of choosing one approach, it makes more sense to combine both. Why this work? Because it's more accessible for studies or for students, helps reduce stigma, encourages early help seeking, uses resources more efficiently. Policy takeaway, keep investing in structured programs, use peer support as a first step into care, focus on making services accessible and scalable. So accessibility assessment, political, it fits strongly, and organization, AI, capacity is strong as well. In social, it's partial fit, and in resources, it's partial fit. The recommended model, evidence-informed integrated stepped care approach. Clinical services, it's for severe symptoms and crisis. It's tier 1. Tier 4. Tier 3, group CBT and MBCT programs for moderate symptoms. Tier 2, it's for workshops and digital CBT for mild symptoms. Tier 1, it's peer support and mental health literacy. So I talk about tier 1 and tier 2. Tier 3, it's like a scale. This one is depending on the symptoms. If it's very severe, we recommend to go to the clinic with a specialist. It's tier 4. Tier 3, it's moderate symptoms. Tier 2, it's for mild symptoms. Tier 1 is for the consultation with the peer support. Strategies. Priority 1, implement digital CBT. Timeline short term. It lead student wellness services, and it costs low cost, which is good. Priority 2, expand group CBT availability. Medium term, 6 to 12 months. Counseling services, and this evidence strength very high, and the cost is higher because it's personnel and training costs. Priority 3, formalize peer support as tier 1 entry point. It's short term, and the evidence strength is low to moderate, and the cost is moderate as well. Priority 4, develop culturally adapted programs. Timeline is medium term, 6 to 12 months. The evidence strength is emerging, and the cost is moderate. Priority 5, pilot stepped care evaluation. Timeline is long term, 12 to 24 months. In strength, it generates University of Waterloo specific evidence. and the cost is moderate to high. In conclusion, we can say anxiety and depression are significant concerns among engineering students, impacting academic success and overall well-being. Structured mental health programs show the strongest clinical evidence for reducing symptoms, while peer support plays a critical role in accessibility, stigma reduction, and help seeking. An integrated, stepped care approach effort the most effective and practical solution. And this is the preferences. And thank you.
Thank you very much, Bosho, Ekata, and other members of this group for your insightful presentation. Do we have any questions for these members? Now we go to our final presentation for the evening.
Hello.
Are you seeing the screen? Those persons
Yes.
online? Okay, good.
Okay, hello everyone, good afternoon. And we are group 2 from the learning stream of research, evidence-informed decision making. And Gulistan, my colleague, will be starting the presentation and I'll continue from there.
Thank you, Abiel. Hello, everyone. I'm Gülistan Altay. I am internationally educated physician from Turkey. I was infection disease and clinical microbiologist. And now I'm working as a health system navigator at a community health center in Niagara region. And I'm also certified Red Cross, Canadian Red Cross first aid and CPR instructor. I'm teaching first aid, CPR, and BLS. And let's start our presentation. And in 2022, there were 1.29 million unnecessary emergency department visits. Can you imagine without 1.29 million unnecessary emergency department visits, how would our emergency department looks like? And normally, ideally, for non-emergency health concerns, primary care should be our first point of care. If we have primary care like family doctors, nurse practitioner clinics, or community health centers, and if we don't have walk-in clinics and the pharmacists that care could be our options. If we have minor illnesses and injuries, not emergencies, we can use urgent care centers. In Niagara region, there's 2 urgent care centers, but their working hours is very limited, 10 a.m. to 8 p.m. Also, some region has a virtual urgent care options. Actually, I learned urgent care existence after I started working community health center. I didn't aware there is any differences with urgent care, emergency care, if you know before that. And there's other ways to also get care. One of them is the Health 811. You can talk with the nurse and get some advice, and some mental health support lines. If it's the serious injury or illness, we should call 911 or go to the nearest emergency department. Ontario has 163 emergency departments, and the emergency departments are essential to Ontario's healthcare system, but they are facing increasing pressure from high patient volume and a shortage of the staff and the long waiting times. They are meant to be treat urgent and emergent healthcare issues, but if the people couldn't get timely care from their primary care, they are choosing to visit emergency departments. Patients go to the emergency departments. They are doing triaging to give care, most urgent ones, timely, and they are doing one of the tools for the triaging is the Canadian triage and acuity scale. And this scale depends on the severity of their patient's condition. Level 1 is the serious one, is resuscitation, and they immediately need to see the doctor. And level 2 is emergent, level 3 is urgent, level 4 is less urgent, and they can wait longer. And level 5 is non-urgent. Even their treatments or the intervention could delay, or they can refer to the other care options. You can see these graphics show that 10 years, in 10 years, how many people visited, patients visited ED, and they are showing the Canadian triage and acuity scale. And the darkest color is the level 1, serious one, and the lightest one is the level 5, is non-urgent clients. The between two annually between 5 million to 6 million people visiting ED department in Ontario. And you can see this is the in 2022, 2023's the scale, you know, the Canadian triage and acuity scale. They are showing this graphic, and the level 4 almost 18% of the visitors, annual visitors, and level 5 almost 67%. They are total like a 23% of the total annual ED visitors counting, and like a 1.29 million unnecessary low acuity patients visiting ED departments, and if, they can get care from the primary care or other clinics. But only 41% of the Ontarios get same day or next day appointments from their primary care provider. That's why people only option is they have is ED departments. If I'm as a patient visit my primary care like a family doctor, my direct cost is only $56 of the system. If I same you know the health issue, I visit ED departments, my direct cost is going to be 165, almost 3 times more. And the Ontario's spending is getting higher. It was like around 800 millions, now is more than 1.2 billions. And these unnecessary visits, you know, the biggest contributor for our waiting time. And they check 2013 is average waiting times after triage to seeing doctor, 87 minutes, but after 2022 is going to, it was to 118 minutes. In some places, some, you know, the locations, some hospitals, even 257 minutes. Waiting times, longer waiting times. Would you like to stay in ED to see a doctor, or would you like to left? Would you leave the emergency department? And this is the left without being seen rate. You can see in 2018 it was 3.5 people left the ED department without seeing doctors. In 2022-23 it was 5.3, and some hospitals it was 14.3. It is the highest ones, and it is mind-blowing. And I was one of them. Actually, I got sick. I couldn't reach my primary doctor. I went ED, and waiting time around the 3 hours, and I didn't wait and left. And also these unnecessary visitors for the ED departments is affecting our quality of care at the emergency departments. And some of the they are delaying the diagnosis, mismanagement, causing mismanagement and unsafe discharge decision. And I want to bring your attention to our Niagara region. I'm working Community Health Center. I'm working Niagara region, and this is the more current data. In February 2026, Ontario's average waiting time is 1.8 hours. In Niagara Falls Hospital's average waiting time is 2.3 hours. As you know, Ontario has 163 hospitals. Niagara Falls Hospital is the worst in the worst 40 hospitals. And this is more detailed data, is showing average waiting time. The second one is the length of stay, low urgent condition. The third one is the length of stay, high urgent condition. And the last one is the length of stay, people waiting to admit to hospital. You can see in Niagara Falls Hospital, 34.4 hours they are waiting to admit to hospitals, and their actually target is 8 hours, but they are waiting 34 hours. All around the year, Niagara Falls Hospital is above the Ontario's average waiting time. This is the Niagara Health's annual 2025 report, showing that how many people visited ED department and the urgent care in Niagara Health. And luckily, a lot of people knows urgent care, and 33,000 people visited urgent care, and 150,000 people visited ED departments. And Niagara had trying to expand their access to primary care, supporting team-based models and building more connected systems to prevent patients to rely on ED departments. Working community health center in our scenario, Niagara Community Health Center start to identifying some initiatives to divert non-urgent patients away from the Niagara Falls ED department, and they actually hired a lot of primary care provider, much more same-day appointment is available. Also, they extended their hours, but also they want to explore technological-based solution like using telemedicine. And they ask Abigail and us to examine the effect of the using after-hours telemedicine interventions. And before we search, we need to well-defined specific question to identify appropriate resources and search relevant, studies. That's why we use a PICO format, and our population is community health center patients. Our intervention is access after hours telemedicine for acute non-urgent conditions, in addition to usual care. Comparison is the usual care alone. Outcome is affect the number of emergency department visits. We don't want to, of course, our goal is to reduce number of emergency visits, but we cannot say to our question, we don't want to miss the opposite results. And our question is, among patients at community health centers, does access to after-hours telemedicine for acute non-urgent conditions, in addition to usual care, compared with usual care alone, affect the number of emergency department visits? Our objective is to compare the number of emergency department visits between the patients with access to our after-hours telemedicine, in addition to usual care, and those receiving usual care alone. When we start searching to try to find the best evidence to answer our question, as you know, when I search, entered our keywords, TRIP database giving 1,000 results, PubMed giving hundreds results. This is so overwhelming. We don't have a capacity, we don't have a time. And as Saida said, we don't want to lost in rabbit hole. That's why we want to find the strongest evidence find the answered our question, and we used 6S pyramid model, and this model is a layer of hierarchic resource of evidence, and we start from the top to go to the bottom, and to find the highest quality, more trustworthy, less bias studies, and we found one audit reports, but the audit reports not the specific of the telemedicine using, and it's specific of the ED departments we use for the contents and this data. And then we found systematic reviews, and we found individual studies. And we have a inclusion and exclusion criteria. Our inclusion criteria was after 2015 studies, telemedicine in primary care or community care, and we used level 3 and higher in the 6X pyramid. And our exclusion criteria: scheduled appointment, routine follow-up appointment, telemonitoring, and the health coaching with the telehealth. Our key findings are: telemedicine improves access but may increase overall healthcare utilization by creating new demand because new existence. And compared to ED-initiated care, it may reduce subsequent utilization, but findings are inconsistent. Limited evidence show modest reduction in ED visits and admissions, particularly in pediatric population. And overall evidence low quality, heterogeneous, and limiting confidence.
All right, I will continue on the second part of the presentation, and it will start with the critical appraisal. So when we found the systematic reviews, and what we did was use the CASP checklist, which is a critical appraisal tool for systematic reviews, and we reviewed using the 10 criteria, and what we found was both systematic reviews were above 6 score, which is a moderate quality, and we found strengths and limitations of the studies. And some of the strengths we found was that they both had a clearly focused caution, and they used a comprehensive search strategy with multiple databases searched like Medline, Cochrane Library, and others. And they also used a standard appraisal tools like CASP checklist. There were multiple reviewers involved in the study selection and data extraction of these systematic reviews. And some of the limitations were the studies included in the systematic reviews were medium to low quality, and there was heterogeneity in the studies. Like, for example, the outcomes they measured differ, so they were not able to do meta-analysis. So due to this, the generalizability of these studies would be limited. So regarding the applicability, the population included in the systematic reviews were, in the first systematic review, it was adults, and in the second systematic review, it was children less than 16 years of age. Since it is not taking the study in the general population, it is partly applicable. And in the setting, it's just similar setting to Canada. It was done in developed countries, and the political situation and the social context are similar, though not identical. So it's partly applicable. And the practicality, there were some resources and system constraints to some barriers to implementation. For example, the funding, there was limited funding. There might be limited funding because it's a new program and it might be difficult to find funding. There might be staff shortages because you are implementing a new program and you have to hire more staff, and this might lead to burnout of staff already existing in the community health center. And in the rural and remote areas, that there might be unequal access. And usually when we are implementing a new program, there will be a resistance to change from both the healthcare system, from the healthcare personnel and the patient perspectives. And also, since it's a new program to be implemented in the community health center, there will be lack of training, and we have to give training to the staff. So in general, there is limited high quality evidence to guide these decisions. So the interpretation is similar to the key findings. Though telemedicine has showed some promise, there is we should be cautious because there is increased risk of bias and limited generalizability. And the evidence we could find is moderate. And though it might decrease the emergency department visits, it might also increase the overall healthcare use, and this might lead to more costs of healthcare. So it can be used as a complement to existing services, but it can't be used as a standalone solution. So the general conclusion is it remains uncertain. Its role in reducing hospital demand is not yet clear. So the conclusion part, we have telemedicine as a potential to improve access to care, but its effect on reducing the emergency department utilization is not consistent across studies, and this might lead to higher overall healthcare use. So based on this, what we can recommend is, since the data we found is a moderate quality research, we need a high quality research to strengthen the evidence base. So it's difficult to implement it right away. So what we can do is a 6 months pilot after our telemedicine service at the, for example, Niagara Community Health Center. And this is with the aim to improve the access to primary care for the non-urgent cases. And what we will evaluate based on this is its impact on emergency department utilization, the patient outcomes like patient satisfaction, and in the general, the cost-benefit analysis. This is our presentation, and these are the references we use it. Thank you for your patience and attention.
Now we're at the end of today's proceedings. Do we have any questions for Abiel and Gulistan? You can post your question in the chat, or you can just go ahead. As we come to the close of today's IEHP-CAN Healthcare Workforce in Canada Summit, I want to take a moment to reflect on what we have collectively experienced throughout the course of the different activities today. It's not just about information, it's also about the connection, clarity, and direction. Across the different learning streams, the profession-specific discussions, the panel discussion, and the one-on-one conversation that you all have as IHPs with your peers, with the different facilitators or panelists that were here earlier. I'd like to say there is no single way, but there are many possible pathways. And more importantly, progress is not about waiting, okay? It's about positioning, where we've heard about the realities of the licensure pathways. This is what we are accustomed to. That's what we have been trying to navigate or supporting or IHPs in navigating. The importance of entering the workforce early and strategically cannot be overemphasized. The value of networking, mentorship, and community is also key and critical. And the growing role of data. So we went through quite a bit of presentations from our data analytics learning stream and also from our research learning stream. And so all of these different learnings, they brought some amount of statistics, research, or evidence to inform the decisions, suggestions, or recommendations. For many international educated healthcare professionals, the challenge is not a lack of skill or experience, and you would see some of those being displayed earlier today in the different activities. It's a matter of navigating a rather complex and often fragmented system. But what today has demonstrated is that there are people who have navigated this path. So we have success stories, persons who've gotten into residency after how many attempts, and the list goes on. Persons who've passed their exams after maybe taking the exam and failing. And some of these also are quite costly. There are opportunities, and if approached strategically, then you can be successful as well. And so whether it is reaching out to a mentor or applying to a role or exploring a new pathway, I'd say to all our IHPs, be open to building networks, expanding your network, progress begins with one intentional step. And so once you make that intentional step, I would say to you that the rest is left for you to celebrate. I also want to extend my sincere thanks to our speakers or facilitators from the start of the session, or different community partners that joined. Also, our Public Health Association of Canada, facilitator Pegeen Walsh, that was here with us earlier. The facilitators for the different breakout sessions as well: medicine, nursing, pharmacy, dentistry. And to you, most of all, our participants or IHPs that we serve within the program. We appreciate you sharing the day with us. Your contribution and what makes this work meaningful and impactful will not go unnoticed. The conference is not the end of the conversation. It's really just a starting point. And so we look forward to continuing to support you in your journey through the IEHP-CAN program and beyond. Thank you again for your time and engagement and your commitment to building your future in Canada's healthcare system. Have a great evening, and we do hope to stay connected. Thank you all.